And welcome back to another chapter of Advanced Pathophysiology. Today we're talking about Chapter 16, Pain, Temperature Regulation, Sleep, and Sensory Function. This chapter we are reading pages 469 to 486. So if we're looking at our pages here, 486 pretty much is your somatosensory function and the special senses. So I would almost say we are going to read up until vision, where aging and things start kicking in. So without much further ado, we jump right into it. Again, my pages may not be the same as yours because I'm using a PDF. Your alterations in sensory function may involve dysfunctions of the general or the special senses. Dysfunctions of the general senses include chronic pain and abnormal temperature regulation. Somatosensory alterations include tactile, proprioceptive, and vestibular dysfunction. Pain is a unique sensory experience that, although universally described as unpleasant, is nonetheless essential to an individual's survival. Pain provides protection by signaling the presence of disease or injury. Unlike pain, which need not be a part of everyday life, temperature is carefully monitored and regulated within clearly defined normal limits. Like pain, however, variations in temperature can signal disease. Fever is a common manifestation of dysfunction and is often the first symptom observed in an infectious or inflammatory condition. Sleep is a normal cyclic process that restores the body's energy and maintains normal functioning. Sleep is so essential to physiologic and psychologic function that sleep deprivation causes a wide range of clinical manifestations. Prolonged deprivation or disruption of sleep ultimately leads to serious dysfunction. The special senses of vision, hearing, touch, smell, and taste are the means by which individuals perceive stimuli that are essential for interacting with the environment. Special sensory receptors are connected to specific areas of the brain through the afferent pathways of the peripheral and central nervous system. Each of the special senses thus involve a connected system of organs and tissues that receive stimuli and send sensory messages to the areas of the CNS, where they are processed and guide behavior. Dysfunction of special senses include visual, auditory, olfactory, and gustatory, which is our taste. So talking about pain. Pain is one of the body's most important adaptive and protective mechanisms. It is a complex experience composed of dynamic interactions among physical, cognitive, spiritual, emotional, and environmental factors, and cannot be characterized as only a response to injury. The International Association for the Study of Pain, and accepted by the American Pain Society and the World Health Organization, define pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. McCaffrey defined pain as whatever the experiencing person says it is, existing whenever he says it does. Vidal defines pain as a symptom, not a clinical sign, diagnosis, or disease. So, which is it? Well, that's for higher beings to figure out. Theories of pain. The theories of pain include the specificity theory, pattern theory, gate control theory, and neuromatrix theory. The specificity theory proposes that pain and touch are carried on distinct pathways that project to distinct brain centers. Injury activates only certain specific pain receptors and fibers that project to the brain. Intensity of pain is directly related to the amount of associated tissue injury. The difference between pricking one's finger with a needle would cause minimal pain, whereas cutting one's hand with a knife would produce more pain. The theory is useful when applied to specific injuries and acute pain associated with them. It does not account for chronic pain or cognitive and emotional elements that contribute to more complex types of pain. Your pattern theory proposes that any somatic sense organs respond to dynamic range of stimulus intensifies or intensities. Different sense organs have different levels of responsiveness to stimuli with different spatial and temporal profiles of firing. The patterns of impulse intensity are encoded in the central nervous system. The pattern theory is limited because it does not account for all types of pain experience. Your gate control theory integrates and builds upon features of other theories to explain the complex, multidimensional aspect of pain perception and pain modulation. Pain transmission is modulated by a balance of impulses conducted to the spinal cord, where cells in the substantia gelatinosa function as a gate. The spinal gate regulates pain transmission to higher centers in the CNS. Large myelinated alpha or A delta fibers and small unmyelinated C fibers respond to a broad range of painful stimuli. These fibers terminate on interneurons in the substantia gelatinosa and open the spinal gate to transmit the perception of pain. Closure or partial closure of the spinal gate can occur from non-nociceptive stimulation carried on large A beta fibers, decreasing the pain perception. This is why rubbing a painful area may alleviate some of that discomfort. Other efferent CNS pathways descend to the spinal cord and may close, partially close, or open the gate, modulating the pain experience. The gate control theory, bolstered by processing and understanding neuronal pathway is the peripheral and central nervous system, has greatly advanced the understanding of pain. As good as the GCT has been, however, there are observations about phantom pain in paraplegics and other pain syndromes that do not fit into the theory box. Your neuromatrix theory, therefore, is an advancement of the gate control theory and proposes that the brain produces patterns of nerve impulses drawn from various inputs, including genetic, sensory discriminative, affective motivational, and evaluative cognitive experiences. The qualities individuals normally feel from the body, including pain, also can be felt in the absence of inputs from the body. In other words, stimuli may trigger the patterns but not produce them. Your neuromatrix patterns are normally activated by sensory inputs from the periphery, but may originate independently in the brain with no external input. The pain experience involves an extensive network of brain regions and networks that may shift and evolve over time. The neuromatrix theory illustrates the plasticity of the brain. It does not supplement the understanding of the gate theory and what it has been learned about peripheral inflammation, spinal modulation, and midbrain descending control of the pain. The neuromatrix theory expands on the gate control theory by explicating a body self that provides a holistic, integrated, dynamic consideration of pain. However, there are many different kinds of pain, and no single theory is adequate to explain the complex dynamics of the pain experience. Continuing research is advancing the understanding of the neural mechanisms of pain. That brings us to the neuroanatomy of pain. The integrated function of three components of the nervous system mediates the sensation, perception, and response to pain. The afferent pathways, which begin in the peripheral nervous system, travel to the spinal gate in the dorsal horn, and then ascend to the higher centers in the CNS. The interpretive centers located in the brainstem, midbrain, diencephalon, your thalamus, hypothalamus, epithalamus, and subthalamus, and cerebral cortex, and the efferent pathway that descends from the CNS to the dorsal horn of the spinal cord. The processing of potentially harmful noxious stimuli through normally functioning nervous system is called the nociception. Nociceptors are free nerve endings in the afferent peripheral nervous system that selectively respond to different chemical, mechanical, and thermal stimuli. When stimulated, they cause nociceptive pain. Nociceptors are unevenly distributed throughout the body, so the relative sensitivity to pain differs according to their location. An example of this is your fingertips have more nociceptors than the skin of the back, and all the skin has many more nociceptors than the internal organs. Unlike sensory neurons of the special senses of vision, gustation, and olfaction, which are required to detect only one type of sensory stimulus, primary nociceptors or nociceptive afferents have the remarkable ability to detect a wide range of stimuli. To do this, nociceptors are equipped with an array of transduction channels that can sense different forms of noxious stimulation and at different intensities. In addition to the previously well-studied voltage-gated potassium, sodium, and calcium channels, there are multiple types of transmembrane receptors, which reside on naked nerve endings and respond to a variety of physical, chemical, and thermal stimuli. So this box here has stimuli that activate nociceptors or pain receptors. I'll leave this up for just a moment. Again, as always, pause when needed. Nociceptors, primary order neurons, are categorized according to the stimulus to which they respond and by the properties of the axons associated with them. Your A delta fibers are lightly myelinated, medium-sized fibers that are stimulated by severe mechanical deformation or by mechanical deformation and or extremes of temperature. Your alpha-delta fibers rapidly transmit sharp, well-localized, fast pain sensation. These fibers are responsible for causing reflex withdrawal of the affected body part from the stimulus before the pain sensation is perceived. The smaller unmyelinated C fibers are polymodal and are stimulated by mechanical, thermal, and chemical nociceptors. The unmyelinated C fibers slowly transmit dull, aching, or burning sensations that are poorly localized and longer lasting. So the A beta fibers are large myelinated fibers that transmit touch and vibration sensations. They do not normally transmit pain, but play a role in pain modulation. Nociception involves four phases: the transduction, transmission, perception, and modulation. So, pain transduction begins when tissue is damaged by exposure to chemicals. Your mechanical or thermal noxious stimuli and is translated into electrophysiological activity. This causes the activation of nociceptors. Your pain transmission is the conduction of pain impulse along the alpha delta and C fibers into the dorsal horn of the spinal cord. Here they form synapses with excitatory or inhibitory interneurons that may branch into ascending or descending collaterals for one or two cord segments in the neuronal projections, called the dorsolateral tract. Eventually, all of the primary afferent terminate or interneurons in the marginal layer or substantia gelatinosa of the spinal cord. The impulses then synapse with projection neurons, cross the midline of the spinal cord, and ascend to the brain through two lateral spinothalamic tracts. The neo-spinothalamic tract, or the anterior spinothalamic tract, carries fast impulses for acute sharp pain. The paleospinothalamic tract, or lateral spinothalamic tract, carries the slow impulses for dual and chronic pain. The fast sharp pain is perceived first, followed by dull throbbing pain. These tracts connect to the reticular formation, hypothalamus, thalamus, and limbic system. The impulses are then projected to the somatosensory cortex for interpretation of location and intensity of pain, and to other areas of the brain for an integrated response to the brain. So here you see the transmission of pain sensation. I'll leave this up for just a moment and we'll keep on keeping on. Again, as always, pause as needed. So here you see the nociceptor pathway. And here's the central nervous system pathway. Pain perception is the conscious awareness of pain that occurs primarily in the reticular and limbic system and the cerebral cortex. Three systems interact to produce the perception of pain, and it changes with age. The sensory discriminative system is mediated by the somatosensory cortex and is responsible for identifying the presence, character, location, and intensity of pain. The affective motivational system determines an individual's conditioned avoidance behaviors and emotional response to pain. It is mediated through the reticular formation, limbic system, and brainstem, with projections to the prefrontal cortex. The cognitive evaluative system overlies the individual's learned behavior concerning the experience of pain and can modulate perception of pain. It is mediated through the cerebral cortex. Pain threshold and tolerance are subjective phenomena that influence an individual's perception of pain. They can be influenced by genetics, gender, cultural perceptions, expectations, rural socialization, physical and mental health, and age. So here in this table you see the pain perception in infants, children, and an older person. So again, pause, take a look at it. So pain modulation. Pain modulation involves many different mechanisms that increase or decrease the transmission of pain signals through the nervous system, depending on the mechanism. Modulation can occur before, during, or after pain has already been received, or perceived rather. The pathway of modulation. Descending inhibitory or facilitatory pathways, nuclei, and neurotransmitters inhibit or facilitate pain. Afferent stimulation of particularly the periaqueductal gray and Rath nucleus in the midbrain stimulates efferent pathways, which inhibit afferent pain signals at the dorsal horn. The rostroventromedial medulla stimulates efferent pathways that facilitate or inhibit pain in the dorsal horn through the dorsal lateral furniculus. Inhibition pathways activate opioid receptors and inhibit release of excitatory neurotransmitters, facilitate the release of inhibitory neurotransmitters, or stimulate inhibitory interneurons. So here you see a diagram representing the central mechanism of pain modulation. The segmental inhibition of pain occurs when the alpha-beta fibers, which synapse in the dorsal horn along their nociceptive alpha-delta and C fibers counterparts, are stimulated, and the impulses arrive at the same spinal level as impulses from the alpha-delta or C fibers. They stimulate an inhibitory interneuron and decrease pain transmission. An example, rubbing an area that has been injured to relieve the pain. Your conditioned pain modulation is an inhibitory pain system that involves a spinal medullary spinal pathway. Pain is relieved when two noxious stimuli occur at the same time from different sites. This is also known as the heterosegmental pain inhibition, and is the basis for pain relief with acupuncture, deep massage, or intense cold or heat. Your expectancy-related cortical activation, a type of placebo effect or nocebo effect, can exert control over analgesic systems to attenuate or intensify pain. In other words, cognitive expectations can cause real, measurable physiologic effects that share some of the same descending pain pathways as the pain modulatory systems. Your neurotransmitters of pain modulation. A wide variety of neurotransmitters act to modulate control over the transmission of pain impulses in the periphery, spinal cord, and brain. The peripheral triggers mechanisms that initiate the release of excitatory neurotransmitters, include tissue injury and inflammation. So your prostaglandins, histamine, bradykinin, tumor necrosis factor alpha, your nitric oxide, and chronic inflammatory lesions like your lymphokines. Activity within nociceptors or damage to them cause release of peptides and neurotransmitters, such as tachykinins. Calcitonin, gene-related peptide, and adenosine triphosphate, your ATP. Glutamate, aspartate, substance P, and calcitonin are common excitatory neurotransmitters in the brain and spinal cord. These substances reduce the activation threshold, leading to an increased responsiveness of nociceptors. So here's a box of mediators that activate your nociceptors. As always, pause to take a look at them, because there are differentiates. Your inhibitory neurotransmitters in the spinal cord include the gamma-aminobutyric acid, your GABAs, and glycine, your norepinephrine, and 5-hydroxytryptamine, or serotonin, contribute to pain inhibition in the medulla and the pons, but can excite peripheral nerves. Your endogenous opioids are a family of morphine-like neuropeptides that inhibit transmission of pain impulses in the spinal cord, brain, and periphery. Their receptors also play a role in various central nervous, gastrointestinal, immune, and other organ system disorders. There's 4 types of opioid neuropeptides: your enkephalins, endorphins, dynorphins, and endomorphins. These neurohormones act as neurotransmitters by binding to one or more G-protein coupled opioid receptors. There are 3 specific types of neuron-opioid receptors: your mu, your kappa, delta. A fourth receptor subtype is the nociception opioid peptide, your NOP, and its ligand in nociceptin orphanin FQ. Each receptor type binds differently with a various type of opioids. They inhibit ion channels in the dorsal horn, preventing the release of excitatory neurotransmitters, such as substance P and glutamate, or other areas of the brain such as the PAG, or rostral ventromedial nuclei in the brainstem. In the midbrain, they influence descending inhibitory pathways. In peripheral inflamed tissue, opioids are produced and released from leukocytes and activate opioid receptors on the sensory nerve terminals. Because leukocyte opioids do not cross the blood-brain barrier, they do not have central nervous system side effects, such as respiratory depression, somnolence, or addiction. Opioid receptors are widely distributed throughout the body and are responsible for general sensation of well-being and modulating of many physiologic processes, including control of respiratory and cardiovascular function, stress and immune responses, gastrointestinal function, reproduction, and neuroendocrine control. So here you see the descending pathway and endorphin response. I'll leave that up for just another moment and we keep going. Enkephalins are the most prevalent of the natural opioids and bind to delta opioid receptors. They are concentrated in the hypothalamus, the PAG matter, the nucleus raf magnus of the medulla, and the dorsal horns of the spinal cord. Your endorphins, or endogenous morphine, are produced in the brain. The best studied endorphin, beta endorphin, binds to mu receptors in the hypothalamus and pituitary gland and is purported to produce the greatest sense of exhilaration as well as substantial natural pain relief. Your dynorphins are the most potent of the endogenous opioids, binding strongly with the Q receptors to impede pain signals in the brain. They play a role in mood disorders and drug addiction, and paradoxically in stimulating chronic pain. Your endomorphins 1 and 2 bind with your mu receptor throughout the brain, brainstem, and gastrointestinal tract, and have analgesic and anti-inflammatory effects. Your nociceptin orphanin FQ produces anti-opioid hyperalgesic effects in supraspinal pathways. It does not interact with opioid receptors. The nociceptor receptor is widely distributed throughout the peripheral and central nervous system. It is associated with inflammation, immune regulation, feeding behavior, and mood elevation, and blunts addictive behavior. In addition to analgesic effects, endogenous opioids are involved in a variety of other functions throughout the body, including modulating of stress and anxiety, feeding behavior, cough suppression, immune and inflammatory responses, and alcohol intake. Endogenous opioids of one type or another are found to bind to almost all tissues in the body and thus affect numerous biologic functions. That leads us to pain threshold and pain tolerance. Your pain threshold is the point at which a stimulus is perceived as pain, and does not vary significantly among people or in the same person over time. Intense pain at one location, however, may cause increase in the threshold in another location. For example, a person with severe pain in one knee is more likely to experience chronic back pain that is less intense. This phenomenon is called perceptual dominance, because the perceptual dominance pain at one site may mask other painful areas. Pain tolerance is the duration of time or the intensity of pain that an individual will endure before initiating overt pain responses, and is generally decreased with repeated exposure to pain. Pain tolerance is influenced by the person's cultural perceptions, expectations, rule behaviors, physical and mental health, gender, age, fatigue, anger, boredom, apprehension, and sleep deprivation. Tolerance may be increased by alcohol consumption, persistent use of pain medication, hypnosis, warmth, distracting activities, and strong beliefs or faith. Your clinical descriptions of pain. Pain can be described in a variety of ways because of the complex nature of pain. However, many terms overlap and more than one description is often used. The broad categories of pain are summarized in box 16.2 here. Some of the most common clinical pain presentations are summarized in the following sections. So, as always, please pause because there's going to be a lot of different sections here. From your neurophysiologic pain, your neurogenic pain, your temporal pain, regional pain, etiologic pain. So, we'll jump into acute pain. Acute pain, or nociceptive pain, is a normal protective mechanism that alerts an individual to a condition or experience that is immediately harmful to the body and mobilizes the individual to take prompt action to relieve it. Your acute pain is transient, usually lasting seconds to days, and sometimes up to 3 months. It begins suddenly and is relieved after the chemical mediators that stimulate pain receptors are removed. The stimulation of the autonomic nervous system results in physical manifestations, including an increased heart rate, hypertension, diaphoresis, and dilated pupils. Anxiety related to pain experience, including its cause, treatment, and prognosis, is common, and there is expectation of limited duration. Acute pain arises from cutaneous and deep somatic tissue, or from visceral organs, and can be classified as somatic, visceral, or referred. Your somatic pain arises from your muscles, bones, joints, and skin. It is either sharp and well localized, or dull, aching, throbbing, and poorly localized, as seen in polymodal C fiber transmissions. Visceral pain is transmitted by C fibers and refers to pain in internal organs and the lining of body cavities, with an aching, gnawing, throbbing, or intermittent cramping quality. It is transmitted by sympathetic afferent and tends to be poorly localized because of lesser number of nociceptors in the visceral structures. Visceral pain is associated with nausea and vomiting, hypotension, restlessness, and in some cases shock. It often radiates or is referred. So your referred pain is felt in an area removed or distant from its point of origin. The area of referred pain is supplied by the same spinal segment as the actual site of pain. So impulses from many cutaneous or visceral neurons converge on the same ascending neuron, and the brain cannot distinguish between the two. Because the skin has more receptors, the painful sensation is experienced at the referred site instead of the site of origin. For example, an inflamed gallbladder or pancreas may refer pain to the shoulder or scapular region. Referred pain can be acute or chronic. So this illustration here is common areas of referred pain and their associated sites of origin. So that was all acute. Now on chronic pain. Chronic or persistent pain is usually defined as lasting more than 3 to 6 months and is pain lasting well beyond the expected normal healing time. Chronic or persistent pain serves no purpose, is poorly understood, and is often accompanied by anxiety and depression, and causes suffering. It often appears to be out of proportion to any observable tissue injury. It may be ongoing, like low back pain, or intermittent, like migraine headaches. Changes in the peripheral and central nervous system that cause dysregulation of nociception and pain modulation processes are thought to lead to chronic pain. Your neuroimaging studies have demonstrated brain changes in individuals with chronic pain, which can lead to the maintenance of pain even in the absence of the original nociceptive input. These negative manifestations of chronic pain are thought to be caused by, in part, the stress of coping with continuous pain and may be reversible when pain is controlled. Because it is not yet possible to predict when acute pain will develop into chronic pain, early treatment of pain is encouraged. Your neuropathic pain is considered chronic pain, initiated or caused by a primary lesion or dysfunction in the nervous system, and leads to long-term changes in pain pathway structures and abnormal processing of sensory information. There is amplification of pain without stimulation by injury or inflammation. Neuropathic pain is often described as burning, shooting, shock-like, or tingling. It is characterized by hyperalgesia, increased sensitivity to a normally painful stimulus, or allodynia, the induction of pain by normally non-painful stimuli. Neuropathic pain is classified as either peripheral or central and is associated with central or peripheral sensitization. Your peripheral neuropathic pain is caused by peripheral nerve lesions and an increase in the sensitivity and excitability of primary sensory neurons and cells in the dorsal root ganglion. Your peripheral sensitization. Examples include nerve entrapment, diabetic neuropathy, and chronic pancreatitis. Your central neuropathic pain is caused by a lesion or neuroplastic changes in the brain or spinal cord. A progressive repeated stimulation of group C neurons that wind up in the dorsal horn leads to increased sensitivity of central pain signaling neurons. That's central sensitization. The result in pathologic changes in the CNS that cause chronic pain. So, for instance, an example is a brain or spinal cord trauma, tumors, vascular lesions, multiple sclerosis, your Parkinson's disease, your post-herpetic neuralgia, and your phantom limb pain. The following mechanisms have been implicated in the cause of neuropathic pain. So, for instance, changes in sensitivity of neurons, lower threshold with peripheral and central sensitization, spontaneous impulses from regenerating peripheral nerves, your alterations in the dorsal root ganglion in response to the peripheral nerve injury, and neurotransmitters, reorganization of nociceptive neurons, loss of your GABAergic pain inhibition in the spinal cord, the activation of micralgia and upregulation of nociceptive chemokines and their receptors, and lastly the structural and functional alteration in brain processing neural networks. So comparison of acute and chronic pain is summarized in the following table here, and common chronic pain conditions are listed in the next table after that. So again, pause. Pause and take a look at the comparison of acute and chronic pain, whether it's the experience, the source, the onset, duration, pain identification, your signs, patterns, actions. Again, let me, here, I'll try to leave as much as possible in one spot. Again, pause as needed. And then here is your common chronic pain condition. So I'll leave that up about here. Again, feel free to pause so you can read through this. An overview of chronic pain syndromes. Specific spinal pain and nonspecific spinal pain are global, common, chronic, and disabling pain conditions, which we'll see in Chapter 18. The prevalence of nonspecific low back pain is about 23%, with 11 to 12% of those affected being disabled. Your prevalence estimates and definition of risk factor vary among studies, depending on the definition of low back pain used. Acute back pain is relatively rare, and many individuals of all ages have chronic recurrent back pain. Common causes include muscle tension and spasm, your fibromyalgia, degeneration, including disc herniation, your lumbar stenosis, osteoarthritis, fractures, mostly in those with osteoporosis. Both cortical and spinal alterations in pain processing is associated with a low back pain. Treatment is individualized and often ineffective, and the personal and societal burden is great. Your myofascial pain syndrome, or MPS, is a regional pain syndrome associated with injury to muscle, fascia, and tendons, and includes myositis, fibrositis, myofibrositis, myalgia, and muscle strain. These conditions involve myofascial trigger points within a taut band of skeletal muscle. The pain may be the result of a low threshold mechanosensitive afferent projecting two sensitized dorsal horn neurons and the development of peripheral and central sensitization. Your neuroaxonal degeneration with alteration in neuromuscular transmission, so extra leakage of acetylcholine at the neuromuscular junction induces persistent contraction, may occur. Compression of the trigger point causes referring pain, motor dysfunction, and autonomic responses. During the early stages of the disorder of pain is localized, but as the disorder progresses, it becomes deep, aching, and more generalized. These, like many other chronic conditions, begin as a result of poor muscle tone, inactivity, muscle or tendon strain, or sudden vigorous exercise, and can evolve into a chronic pain state. Chronic postoperative pain occurs in some individuals and includes nerve injury, complex regional pain syndrome, phantom limb pain, chronic donor site pain, post-thoracotomy pain syndrome, post-mastectomy pain syndrome, joint arthroplasty pain, and post-surgical abdominal and pelvic pain. Plastic. Changes in the peripheral nervous system and central nervous system contribute to allodynia and hypersensitivity. Multimodal approaches to analgesia are needed for pain management, including adequate management of preoperative pain and postoperative management of acute pain. Cancer pain is often chronic and the cause is unknown. Cancers generate and secrete mediators that sensitize and activate primary afferent nociceptors in the area of the tumor, resulting in neurochemical reorganization of the spinal cord, which contributes to spontaneous activity and enhanced pain responsiveness. Cancer pain is greater than inflammatory pain and has decreased expression of the opioid receptors on dorsal root ganglia. Tumors also can secrete neurotrophic factors that contribute to enhanced responsiveness to pain, increasing pressure of the growing tumor on nerve endings, tissue destruction, distension of visceral surfaces, obstruction of ducts and intestines. Chemotherapy, radiation therapy, and surgical procedures also cause pain. Therapeutic approaches to the management of cancer pain have advanced significantly in recent years, particularly in palliative care and hospice programs. Frequent assessment of pain, management of breakthrough pain, and implementation of individualized interdisciplinary therapeutic strategies and rehabilitative techniques, along with frequent evaluations, are essential to optimal cancer pain management. So, your central post stroke pain is a form of central pain associated with a stroke, which occurs along the spinal thalamo-cortical pathway and produces a hypersensitivity on one half of the body. There may be hyperexcitation in the damaged sensory pathways, damage to the central inhibitory pathways, or a combination of the two. The pain can be persistent or intermittent, burning or aching, stabbing, widespread, or focused. Allodynia may occur. The symptoms usually develop weeks or months after the stroke and can be difficult to differentiate from other causes of pain. Your phantom limb pain is pain that an individual feels in an amputated limb, usually distally, whether it's your hands or your feet, after the stump has completely healed, so 1 to 3 months after the amputation. Non-painful phantom limb sensation occurs in almost all amputees, but the sensations usually fade with time. This is distinguished from the syndrome of phantom limb pain, a chronic pain occurring in about 60 to 80% of amputees. It is more likely to appear in individuals who experience pain in the limb before amputation. Therefore, about the cause of phantom limb pain include regeneration or hyperactivity of injured or cut peripheral nerves, your scar tissue or neuroma formation in the cut peripheral nerves, spinal cord deafferentation, nerve injury causing sensitization of dorsal horn neurons, mediated by release of glutamate and neurokinins, and alterations in the thalamus and cortex. It has been proposed that CNS integration include reorganization of plastic changes in the somatosensory cortex, results in the perception of pain from receptors associated with the amputated limb, even though the limb itself is no longer present. The absence of inhibitory effects of the sensory input from the missing peripheral body part may cause increased autonomous activity of dorsal horn neurons with pain transmission. The cause is likely multifactorial, contributing to the difficulty of prevention or effective treatment. Your complex regional pain syndrome is chronic neuropathic pain, usually associated with limb injury. Two forms are described: complex regional pain syndrome 1, associated with injury but no apparent nerve injury, and complex regional pain syndrome 2, with evidence of nerve injury. So remember, complex regional pain 1, no nerve injury. Syndrome 2 has nerve injury. The symptoms of both forms are similar. Your CRPS is distinguished from other chronic pain disorders by signs of autonomic and inflammatory changes in the pain region of the injured nerve. There are autonomic symptoms: changes in skin color, temperature, sweating, alterations in hair and nail growth for the affected limb. Your motor symptoms, a tremor or weakness may be present, and sensory symptoms, either hypersensitivity or allodynia. Your CRPS is further distinguished as warm CRPS, associated with warm, red, and edematous extremities, and cold CRPS, associated with cold, dusky, and sweaty extremities. Acute CRPS is more often associated with a warm CRPS presentation, whereas your chronic CRPS is more often characterized by a cold CRPS presentation. Your peripheral and central sensitization contribute to a pain syndrome, but the mechanisms are unknown. A combination of injury and the presence of inflammatory cytokines and neuropeptides may lead to peripheral nociceptive sensation and physiologic changes in pain transmission and in autonomic and motor symptoms. Pediatrics and perception of pain. Infants and children have the anatomic and functional ability to perceive pain. Pain pathways and cortical and subcortical centers for pain perception, as well as neurochemical associated with pain transmission and modulation, are functional in preterm and newborn infants. The nociceptor system is functional in fetuses by 15 to 20 weeks of gestation, and painful fetal procedures require adequate analgesia. Repetitive, painful experiences and prolonged exposure to analgesic drugs in preterm infants may permanently alter developing synaptic and neuronal pain processing networks, causing irreversible hypersensitivity to pain with subsequent injury. Alterations occur in both the excitatory and inhibitory pathways in the spinal cord, and descending inhibitory processing from the brainstem. Repeated painful procedures require increased amounts of analgesia. Your preterm infants experiencing the stress of repeated painful procedures also have delayed postnatal growth and poor early neurodevelopment, with long-term consequences in both cognitive and motor function. More research is needed to guide selection of analgesic and anesthetic agents and non-pharmacologic therapies for infant pain management in relation to effects on long-term neurodevelopments. Facial expressions, crying, body movement, and lack of consolability are the most consistent expressions of pain in infants. The painful facial expression includes lowered brows drawn together, presence of the vertical bulge and furrows in the forehead between the brows, broad nasal root, tightly closed, scourged eye fissures, angular tongue cusping or cupping, squarish mouth, and chin quiver. There may be finger clenching, writhing, back arcing, and head banging. Physiologic response includes increased heart rate, blood pressure, respiratory rate, although these measures lack sensitivity or specificity. There may be flushing or pallor, sweating, and decreased oxygen saturation. Toddlers also express pain with crying, facial expression, and body language. Older children between the ages of 5 and 18 years tend to have a lower pain threshold than do adults. Children, like adults, have highly individual responses to pain. Any behavioral or physiologic indicators of pain must be carefully and accurately addressed, and adequate treatment for children of all ages. So here are the expressions of pain in an infant. So aging and the perception of pain. Studies on pain perception in the older adult population have yielded conflicting evidence. Some studies show an increase in pain threshold with aging. Others show no change. The varied results are probably a function of independent variation in the sensory discriminative, motivational, affective, and cognitive evaluative components of the pain experience. In general, studies confirm that an increase in the pain threshold occurs in some older adults. This change may be caused by peripheral neuropathies and changes in the thickness of the skin or cognitive impairment. A decrease in pain tolerance is also evident in some older adults and may be related to decreased descending inhibitory modulation, decreased synthesis of neurotransmitters, or decreased opioid receptor density. Women appear to be more sensitive to pain than men. pain in the older adult is also influenced by cognitive function and liver and renal function, including alterations in metabolism of drugs and metabolites, and age-associated brain changes. Pain must be accurately assessed in relation to its effect on cognitive function, coexisting disease, drug interactions, and other reactions to treatment, and an individual's ability to express pain and maintain safety. Poorly managed pain can result in depression, inactivity, and failure to maintain activities of daily living. So here's an article on sex differences and pain. Pause if you wish to read it. You're open to that option as always. Your temperature regulation. Human thermoregulation is achieved through precise balancing of heat production, heat conservation, and heat loss. Normal ranges of body temperatures anywhere between 36.2 and 37.7 overall, but a person's individual body parts may vary in temperature. The extremities are generally cooler than the trunk, and the temperature at the core of the body is generally higher than the surface temperature. Internal temperature varies in response to activity, environmental temperature, and daily fluctuations. Your oral temperatures fluctuate within 0.2 to 0.5 degrees Celsius during a 24-hour period. Women tend to have a wider fluctuation that follow the menstrual cycle, with a sharp rise in temperature just before ovulation. The daily fluctuating temperature is similar in both sexes. Maintenance of body temperature within the normal range is necessary for life. So, control of temperature. Temperature regulation or thermoregulation is mediated primarily by the preoptic anterior area of the hypothalamus. Peripheral thermoreceptors in the skin and the abdominal organs, and the central thermoreceptors in the spinal cord and trigeminal ganglia provide the hypothalamus with information about skin and core temperature. These peripheral thermoreceptors have heat-sensitive ion channels, which are activated at variable temperatures and provide thermotransduction of energy into a neural signal to the hypothalamus. If these temperatures are low or high, the hypothalamus responds by triggering heat production, heat conservation, or heat loss mechanisms. Body heat is produced by the chemical reaction of metabolism and skeletal muscle tone and contraction. The heat-producing mechanism begins with hypothalamic thyrotropin-stimulating hormone release hormone. It stimulates the anterior pituitary to release thyroid-stimulating hormone, which acts on the thyroid gland and stimulates the release of thyroxine. Thyroxine then acts on the adrenal medulla, causing the release of epinephrine into the bloodstream. Epinephrine causes vasoconstriction, stimulates glycolysis, and increases metabolic rate, thus increasing body heat. Norepinephrine and thyroxine activate brown fat thermogenesis, where energy is released as heat instead of an adenosine triphosphate, or your ATP. Heat is distributed by the circulatory system. The hypothalamus also triggers heat conservation by stimulating the sympathetic nervous system, which stimulates the adrenal cortex and results in increased skeletal muscle tone, initiating the shivering response and producing vasoconstriction. By constricting peripheral blood vessels, centrally warmed blood is shunted away from the periphery to the core of the body, where heat can be retained. This involuntary mechanism takes advantage of the insulating layers of the skin and subcutaneous fat to protect core temperature. The hypothalamus relays information to the cerebral cortex about cold, and voluntary responses result Individually, typically bundled up, keep moving, or curl up into a ball. These types of voluntary physical activities, respectively, provide insulation, increase skeletal muscle activity, and decrease the amount of skin surface available for heat loss through radiation, convection, and conduction. The hypothalamus responds to warmer core and peripheral temperature by reversing the same mechanism. The TSH-RH pathway is shut down. The sympathetic pathway is prompted to produce cutaneous vasodilation, decreased muscle tone, and increased sweat production. Hypothalamic stimulation of the cerebral cortex provokes voluntary behavior to reduce heat production and promote heat loss. So here on table 16.5, it shows you the mechanism of heat production and heat loss. So as always, please pause. Read these, make flashcards. It helps you, understand it a little better. So, mechanisms of heat production. There are chemical reactions of metabolism. The chemical reaction that occurs during the ingestion and metabolism of food and those required to maintain the body at rest require energy and produce heat. These processes occur in the body and are in part responsible for the maintenance of core temperature. Your skeletal muscle contraction. Skeletal muscle produce heat through two mechanisms: gradual increase in muscle tone and production of rapid muscle oscillation. Shivering. Both increasing muscle tone and shivering are controlled by the posterior hypothalamus and occur in response to cold. As peripheral temperature drops, muscle tone increases and shivering begins. Shivering is a fairly effective method for increasing heat production because no work is performed and all the energy produced is retained as heat. Your chemical thermogenesis. Chemical thermogenesis, also called non-shivering thermogenesis or adrenergic thermogenesis, results from the release of epinephrine and norepinephrine. Your epinephrine and norepinephrine produce a rapid transient increase in heat production by raising the body's basal metabolic rate. Chemical thermogenesis seems to be different from hormone-triggered increase in the basal metabolic rate. Chemical thermogenesis produces a quick, brief rise in basal metabolic rate, whereas the hormone thyroxine triggers a slow, prolonged rise. Chemical thermogenesis occurs in brown and beige adipose tissue. Brown adipose tissue is rich with mitochondria and blood vessels and is essential for non-shivering thermogenesis. Beige or bright adipocytes are found within the subcutaneous white adipose tissue. White adipocytes store energy, and brown and beige adipocytes produce heat. Beige adipocytes demonstrate transdifferentiation to white adipocytes, and such plasticity allows direct conversion of one cell type into the other. With chronic cold exposure, white to beige conversion increases thermogenesis. Your mechanism of heat loss. Heat loss is achieved through many mechanisms, such as radiation, conduction, convection, vasodilation, decreased muscle tone, evaporation, increased pulmonary ventilation, voluntary measures, and adaptive or adaptations to warmer climates. So, speaking about radiation, radiation refers to heat loss through electromagnetic waves. These waves emanate from surfaces with temperature higher than the surrounding air temperature. Thus, if temperature of the skin is higher than that of the air, the skin and therefore the body loses heat to the air. Conduction. Conduction refers to heat loss by direct molecule-to-molecule transfer from one surface to another. Thus, the skin loses heat through direct contact with cooler air, water, or another surface. In the same manner, the core of the body loses heat to the cooler body surface. Convection is the transfer of heat through current gases or liquids. It greatly aids heat loss through conduction by exchanging warmer air at the surface of the body with cooler air in the surrounding space. Convection occurs passively as warmer air at the surface of the body rises away from the body and is replaced by cooler air, but the process may be aided by fans or wind. Vasodilation. Peripheral vasodilation increases heat loss by diverting core warmed blood to the surface of the body. As the core warmed blood passes through the periphery, heat is transferred by conduction to the skin surface and from the skin to the surrounding environment. Because heat loss through conduction depends on the surrounding temperature, it is minimal to non-existent if the surrounding air or water is warmer than the body's surface. Vasodilation occurs in response to an autonomic stimulation under the control of the hypothalamus. It is useful in instances of moderate temperature elevation. As core temperature increases, vasodilation increases until a maximal dilation is achieved. At that point, the body must use additional heat loss mechanisms. A decreased muscle tone. To decrease heat production, muscle tone must be moderately reduced and voluntary muscle activity curtailed. These mechanisms explain in part the washed-out feeling associated with high temperatures and warm weather. Decreased muscle tone and reduced activity have a limited effect on decreasing heat production. However, because muscle tone and heat production cannot be reduced below a basal body requirement. Evaporation. Evaporation of the body water from the surface of the skin and the linings of the mucous membranes is a major source of heat reduction. Insensible water loss accounts for the loss of about 600 ml of water per day. Heat is lost as surface fluid is converted to gas, so that heat loss by evaporation is increased if more fluid are available at the body surface. To speed this process, fluids are actively secreted through the sweat gland. As much as 2.2 liters of fluid per hour may be lost by sweating. Electrolytes are lost with the water. Therefore, loss of large volumes through sweating may result in a decreased plasma volume, decreased blood pressure, weakness, and fainting. Like the other heat reduction mechanisms, stimulation of sweating occurs in response to sympathetic neural activity and depends on favorable temperature difference between the body and the environment. In addition, heat loss through evaporation is affected by the relative humidity of the air. If the humidity is low, sweat evaporates quickly, but if the humidity is high, sweat does not evaporate and instead remains on the skin or drips off it. Increased pulmonary ventilation, exchanging air with the environment through the normal pulmonary ventilation provides some heat loss. Although it is minimal in humans, as air is inhaled, the air draws heat from the upper respiratory tract. The air is further warmed in the alveoli by the blood in the microcirculation. This warmed air then is exhaled into the environment. This normal process occurs faster at higher body temperatures through an increase in ventilatory rates. Thus, hyperventilation is associated with hyperthermia. Voluntary mechanisms include in response to high body temperatures. People physically stretch out. thereby increasing the body surface area available for heat loss. They also slow down or take it easy, thereby decreasing skeletal muscle work. And they dress for warm weather with light-colored, loose-fitting garments to reflect heat and promote convection, conduction, and evaporation. So heat adaptation, the body of an individual who moves from a cooler to a much warmer climate undergoes a period of adjustment, a process that takes several days, sometimes weeks. At first, the individual experiences feelings of lassitude, weakness, and faintness, with even moderate activity. Body temperatures rise with any work. Within several days, however, the individual experiences an earlier onset of sweating. The volume of sweat is increased, the sodium content is lowered, and skin blood flow increases. Heart rate is decreased and stroke volume increased, so that cardiac output remains unchanged. Extracellular fluid volume increases, so does plasma volume. These physiologic adaptations result in improved warm weather functioning and decreased symptoms of heat intolerance. People's work output, endurance, and coordination increase, and their subjective feelings of discomfort decrease. So, the mechanism of heat conservation. We have vasoconstriction. By constricting peripheral blood vessels, centrally warmed blood is shunted away from the periphery, where radiation conduction and convection would allow heat loss, back to the core of the body, where heat can be retained. This mechanism takes advantage of the insulating layers of the skin and subcutaneous fat to protect core temperatures. We can also conserve our heat via voluntary mechanisms. In response to a lower body temperature, individuals typically bundle up, keep moving, or curl up in a ball. Bundling up involves dressing with several layers of clothing that allows air to be trapped between the skin and the clothing, thus providing an additional layer of insulation. Keeping moving, stamping feet, clapping hands, jogging, or other types of physical activity increase skeletal muscle activity and thus promote heat production. Curling up in a ball decreases the amount of skin surface available for heat loss through radiation convection or conduction. So how does that work though with pediatrics and temperature regulation? Infants and older adults require special attention to maintain body temperature. Term infants produce body heat primarily through the metabolism of brown fat, but it may not be adequately developed for cold stress. They are also unable to efficiently conserve heat because of the infant's small body size, greater ratio of body surface area to body weight with heat loss through conduction and convection, and decreased ability to shiver. Infants have a thin layer of subcutaneous fat and thus are not well insulated as adults. Therefore, it is important to keep infants warm with hats, clothing, blankets. Children also have a greater ratio of body surface area to body weight, fewer sweat glands, lower sweating rate, higher peripheral blood flow in the heat, and a greater extent of vasoconstriction in the cold than adults. They can acclimate to changes in environmental temperatures, but do so at a lower rate than that seen in adults. That leads us to aging and temperature regulation. The older adults have lower body temperatures than younger people. They have poor responses to environmental temperature extremes as a result of slowed blood circulation, structural and functional changes in the skin, an overall decrease in heat producing activities, and the presence of disease. Cold stress in older adults also decrease coronary perfusion. Other factors affecting thermal regulation in the older adult population include decreased shivering response, slowed metabolic rate, sedentary lifestyles, decreased vasoconstrictor and vasodilator responses, diminished or absent sweating, decreased amount of brown fat, desynchronization of the circadian rhythm, undernutrition, and decreased perception of heat and cold. So what does that mean in terms of pathogenesis of a fever? Fever, or febrile response, or pyrexia, is a temporary resetting of the hypothalamic thermostat to a higher level in response to a pyrogenic cytokines and exogenous pyrogens. The pathophysiologic mechanism of fever begins with the introduction of exogenous pyrogens, or endotoxins, produced by pathogens. The most frequent encountered exogenous pyrogens are the lipopolysaccharide complexes in the cell wall of gram-positive bacteria and viruses, released with rupture of the cell wall when the microbe dies. Pyrogenic cytokines, including tumor necrosing factor alpha, interleukin 1, interleukin 6, and interferon gamma, are produced by phagocytic cells as they destroy microorganisms within the host. The final common step for fever generation by pyrogens is the production of prostaglandin E2, also known as PGE2, in both the periphery and the brain. PGE2 acts on warm sensitive neurons in the preoptic area of the hypothalamus. An integrated behavioral, endocrine, and autonomic nervous system response is then initiated. Centers in the hypothalamus and brainstem signal an increase in heat production and heat conservation to raise the set point for body temperature regulation. Peripheral vasoconstriction occurs with shunting of blood from the skin to the body's core. Epinephrine release increases metabolic rate and muscle tone increases. A decreased release of vasopressin reduces the volume of body fluid to the heat. Shivering also may occur. The individual dresses more warmly, decreases body surface area by curling up, and may go to bed in an effort to get warm. Your body temperature is maintained at the new level until the fever breaks. So here is a pathogenesis of fever and an acute phase response. I'll leave this up for just a moment. Again, always pause if you feel like I'm going too quick, but otherwise I shall keep going. The acute phase response is a reaction that occurs when pyrogenic and other cytokines are released in response to infection and inflammation. In addition to fever, other symptoms occur including anorexia, fatigue, malaise, somnolence, and loss of concentration. At the cellular level, inflammatory pyrogenic cytokines promote muscle catabolism and hyperglycemia by stimulating the release of adrenocorticotropic hormone and glucocorticoids to support glucose consuming cells. The hepatic acute phase response involves increasing or decreasing protein synthesis. Your C-reactive protein, mannose binding protein, complement factors, ferritin, ceruloplasmin, serum amyloid A, fibrinogen, and haptoglobin all increase. Albumin, transferrin, retinol binding proteins, and transthyretin are reduced. The erythrocyte sedimentation rate, or ESR, increases as the increase in fibrinogen and other plasma proteins decrease Rouleau formation, allowing the red blood cells to fall faster. Acute phase proteins and ESR can serve as biomarkers for the inflammatory response. The general functions of increased acute phase proteins are to opsonize entrapped microorganisms and their products, active complement, neutralize enzymes, and modulate the host's immune response. See Chapter 7. During fever, arginine vasopressin, AVP, alpha melanocyte stimulating hormone, or alpha MSH, and corticotropin releasing factor, are released from the brain and systemic anti-inflammatory cytokines, again, interleukin 1 receptor agonist and interleukin 10, can act as endogenous cryogens or antipyretics to help diminish and control the febrile response. This antipyretic effect constitutes a negative feedback loop. The antipyretic effect may help explain fluctuations in the febrile response. When the fever breaks, the set point is returned to normal. The hypothalamus responds by signaling a decrease in heat production and an increase in heat reduction mechanisms. The result is decreased muscle tone, peripheral vasodilation, flushed skin, and sweating. The individual feels very warm, replaces warm clothing with cooler clothing, throws off the covers, and stretches out. Once the body has returned to a normal temperature, the individual feels more comfortable, and the hypothalamus adjusts thermoregulatory mechanisms to maintain the new temperature. So there are benefits of fever. Moderate fever aids responses to infectious processes through several mechanisms. A raised body temperature kills many microorganisms and has adverse effects on the growth and replication of others. Higher body temperatures decrease serum level of iron, zinc, and copper, all of which are needed for the bacterial replication. The body switches from burning glucose to a metabolism based on lipolysis and proteolysis, thereby depriving bacteria of a food source. Increased temperature also causes lysosomal breakdown and autodestruction of cells, thus preventing viral replication in infected cells. Acute phase proteins produced by the liver during inflammation bind cations necessary for bacterial reproduction. Heat increases lymphocytic transformation and motility of polymorphonuclear neutrophils, thus facilitating the immune response. Phagocytosis is enhanced, and production of antiviral interferon may be augmented. Because fever is a beneficial response to infection, suppressing fever with antipyrogenic medication should be reviewed carefully. Such treatment should be used only if the fever is high enough to produce serious side effects, such as nerve damage or convulsions, although more studies are needed to guide practice. Infection and fever responses in older adults and in children may vary from those in the adult. Older individuals may have decreased or no fever response to infection. The absence of fever response to infection, and therefore the beneficial aspects of fever production, may explain the increase in morbidity and mortality rates seen in very old individuals. In contrast, children develop much higher temperatures than do adults for relatively minor infections. Your febrile seizures may occur with temperatures greater than 38 degrees Celsius, although most children do not develop febrile seizures until temperatures are much higher. Febrile seizures are more predominant in boys before the age of 5, and genetic factors contribute to susceptibility. Febrile seizures are generally brief and self-limiting, lasting less than 5 minutes in 40% of children and less than 20 minutes in 75%. Although in most instances there appear to be no long-term effects on the child, a small percentage of children may develop epilepsy. A prolonged febrile seizure are associated with the development of temporal lobe epilepsy in children and are probably associated with functional changes in neurons and neural networks. So, fevers of an unknown origin, or FUO, is a fever with a body temperature greater than 38.3 or 101 Fahrenheit. That remains undiagnosed after 3 days of hospital investigation or 2 or more outpatient visits. The clinical category of a FUO include classic, nosocomial, neutropenic, and HIV associated. The history and clinical examination can assist in differentiating possible causes. So, disorders of temperature regulation. Your internal body temperature is maintained within a narrow range. Alterations in regulation of heat production or heat loss can be life-threatening. So we have two extremes that we can go into. Your hyperthermia is the elevation of the body temperature without an increase in the hypothalamic set point. Hyperthermia can produce nerve damage, coagulation of cell proteins, and death. At 41 degrees Celsius, or 105.8, nerve damage produces convulsions in the adult. Death results at 43 degrees Celsius, or 109.4. Your hyperthermia may be therapeutic, accidental, or associated with stroke or head trauma. Prevention of hyperthermia and stroke and head trauma assists in limiting brain injury. Therapeutic hyperthermia is a form of local, regional, or whole-body-induced hyperthermia used to destroy pathologic microorganisms or tumor cells by facilitating the host's natural immune process or tumor blood flow. The forms of accidental hyperthermia are summarized as heat cramps, which are severe spasmodic cramps in the abdomen and extremities that follow prolonged sweating and associated sodium loss. They usually occur in those not accustomed to heat or those performing strenuous work in a very warm climate. Fever, rapid pulse rate, and increased blood pressure accompany the cramps. Treatment involves administration of dilute salt solutions through oral or parenteral routes. You could also have heat exhaustion, which results from prolonged high core or environmental temperatures, which cause profound vasodilation and profuse sweating, leading to dehydration, decreased plasma volumes, hypotension, decreased cardiac output, and tachycardia. Symptoms include weakness, dizziness, confusion, nausea, and fainting. The symptoms of heat exhaustion cause the individual to stop work, lie down, and rest. Ceasing activity decreases muscle work, causing decreased heat production. Lying down redistributes vascular volume. The individual should be encouraged to drink cool fluids to replace fluid loss through sweating. And then a very classic heat stroke, a potential lethal result of an overstressed thermoregulatory center. Heat stroke can be caused by exertion, by overexposure to environmental heat, or from impaired physiologic mechanisms for heat loss. With very high core temperatures greater than 40 degrees Celsius, the regulatory center ceases to function and the body's heat loss mechanisms fail. Symptoms include high core temperatures, absence of sweating, rapid pulse rate, confusion, agitation, and coma. Complications include cerebral edema, degeneration of the CNS, swollen dendrites, renal tubular necrosis, and hepatic failure, with delirium, coma, and eventually death if treatment is not undertaken. Finally, I believe malignant hyperthermia is a potential lethal hypermetabolic complication of a rare inherited muscle disorder that may be triggered by inhaled anesthetics and depolarized muscle relaxants. The syndrome involves either increased myoplasmic calcium release or decreased calcium uptake. This allows intracellular calcium levels to rise, producing sustained, uncoordinated muscle contractions, muscle cell hypermetabolism, increased muscle work, increased oxygen consumption, and a raised level of lactic acid production. Acidosis develops and the body's temperature rises about 1 degree every 5 minutes, with resulting tachycardia and cardiac dysrhythmias. Your hypotension, decreased cardiac output, and cardiac arrest. The syndrome is caused by a defect in the ryanodine receptor. Signs resemble those of coma, unconsciousness, absent reflexes, fixed pupils, apnea, and occasionally a flat electroencephalogram. Oliguria and anuria are common. It is most common in children and adolescents. Treatment includes withdrawal of the provoking agent, body cooling therapy, and drugs that antagonize the ryanodine receptor. This is usually seen in your, you know, OR cases, in the inpatient setting, that is. Now we can go into the opposite extreme, hypothermia. When the core body temperature is less than 35 degrees Celsius. Produces depression of the central nervous and respiratory system, vasoconstriction, alterations in microcirculation and coagulation, and ischemic tissue damage. In a controlled situation, such as a surgical procedure, most tissues can tolerate temperatures as low as 33 degrees Celsius. In severe hypothermia, less than 28 degrees Celsius, ice crystals forming on the inside of the cell causes the cells to rupture and die. Your tissue hypothermia slows the rate of chemical reaction or tissue metabolism, increases the viscosity of the blood, slows blood flow through the stimulated profound vasoconstriction, and suppresses myocardial contractility and induces arrhythmias. Hypothermia may be accidental or therapeutic. In accidental hypothermia, high energy phosphatase, or ATP, is depleted, and in therapeutic hypothermia, ATP storage is preserved. So, if we're looking at accidental hypothermia, an accidental hypothermia is generally the result of sudden immersion in cold water or prolonged exposure to cold environments. At particular risk for accidental hypothermia are infants and older adults, because thermoregulatory mechanisms are immature or altered in these two groups. Also at risk are individuals with conditions that diminish the ability to generate heat. Such as conditions include hypothyroidism, hypopituitarism, decreased liver function, malnutrition, Parkinson's disease, and rheumatic arthritis. Other risk factors include chronic increased vasodilation and decreased thermoregulatory control caused by cerebral injuries, ketoacidosis, uremia, and drug overdoses. In acute hypothermia, peripheral vasoconstriction shunts blood away from the cooler skin to the core in an effort to decrease heat loss, which produces peripheral tissue ischemia. Intermittent reperfusion of the extremities, the Lewis phenomenon, helps preserve peripheral oxygenation. Intermittent peripheral perfusion continues until core temperatures drop dramatically. The hypothalamic center stimulates shivering in an effort to increase heat production. Severe shivering occurs at core temperatures of 35 degrees Celsius and continues until core temperatures drop to about 30 to 32 degrees Celsius. Prolonged shivering can lead to exhaustion of liver glycogen stores. Thinking becomes sluggish and coordination is decreased at 34 degrees Celsius. As hypothermia deepens, paradoxical undressing may occur as hypothalamic control of vasoconstriction is lost and vasodilation occurs, with loss of core heat to the periphery. The hypothermic individual therefore feels suddenly warm and begins to remove clothing. At 30 degrees Celsius, the individual becomes stuporous. Your heart rate and respiratory rate decline, and cardiac output is diminished. Cerebral blood flow is decreased, metabolic rates decline, further decreasing the core temperature. Your sinus node depression occurs with slowing of conduction through the atrioventricular node. In severe hypothermia, core temperatures of 26 to 28 degrees Celsius, pulse and respirations may be undetectable and require resuscitation. Acidosis is moderate to severe. Coagulopathy, ventricular fibrillation, and asystole is common. Surface cooling may cause frostbite and fat necrosis. If hypothermia is mild, passive rewarming may be sufficient. If core temperature is greater than 30 degrees Celsius, active rewarming may also be required. Active rewarming uses warm water baths, warm blankets, heating pads, and warm oral fluids when the individual is fully alert. Core rewarming may be accomplished through administration of warm IV fluids, warm gastric lavages, warm peritoneal lavages, and inhalation of warmed gases, and in extreme cases, an exchange transfusion, warming blood in a pump oxygenator circuit, and mediastinal lavage. Rewarming generally should proceed no faster than a few degrees per hour. Short-term complications of rewarming include acidosis, shock, known as rewarming shock, and dysrhythmias. Long-term complications include congestive heart failure, hepatic and renal failure, abnormal erythropoiesis, myocardial infection or infarction, pancreatitis, and neurologic dysfunction. Your therapeutic hypothermia. Your therapeutic hypothermia is used to slow metabolism and preserve ischemic tissue after brain trauma or during brain surgery, after cardiac arrest, and in neonatal hypoxic encephalopathy. Hypothermia protects the brain by reduction in metabolic rate, ATP consumption, oxidative stress, and the critical threshold for oxygen delivery, modulation of excitotoxic neurotransmitters, and calcium antagonism, preservation of protein synthesis and the blood-brain barrier, decreased edema formation, and modulation of the inflammatory response. Trauma and temperature regulation. Major body trauma has varying effects on temperature regulation, depending on the body system involved. 5 types of traumatic injury that usually affect temperature regulation are your CNS trauma, your accidental injury, hemorrhagic shock, major surgery, and thermal burns. So, if we're talking about central nervous system trauma, CNS trauma that causes CNS damage, inflammation, increased intracranial pressure, or intracranial bleeding typically produces a temperature greater than 39 degrees Celsius. This temperature, often referred to as a neurogenic or central fever, appears with or without relative bradycardia and is not caused by an infection. The temperature sustained does not induce sweating and is highly resistant to antipyretic therapy. Your accidental injury, mild accidental injuries, may produce a slight elevation in core temperature. Moderate to severe injuries result in peripheral vasoconstriction with decreased surface or core temperatures. Core temperature is thought to be inversely related to the severity of the injury and may be a result of decreased oxygen transport to the tissue. In severe injuries, shivering is absent and some alterations in thermoregulation is evident. In hemorrhagic shock, loss of blood volume in hemorrhagic triggers peripheral vasoconstriction and hypoxia, contributing to hypothermia. Risk for subsequent decreases in core temperatures occurs when hemorrhagic shock is treated with unwarmed volume expanding solutions and surgery. That volume expansion with warm solution is recommended to prevent the deleterious effects of hypothermia on cardiac output, cardiac rhythm, and the immune system. In surgery, major surgery often induces significant hypothermia through exposure of body cavities to the relatively cool operating room environment, irrigation of body cavities with room temperature solutions, infusion of room temperature IV solutions, use of drugs that impair thermoregulatory mechanisms, and inhalation of unwarmed anesthetic agents. Anesthesia induces hypothermia, reduces platelet function, and impairs the coagulation cascade, contributing to transfusion requirements and postoperative complications. Use of warmed airguns in IV solutions and perioperative forced air and skin warming procedures reduce intraoperative hypothermia and postoperative complications. Your thermal burns. Large burn injuries produce significant hypothermia because of the loss of the skin barrier to fluid evaporation and the loss of control of the microcirculation in the skin. Severe burns are also compromised and have a normal Severe burns also compromise the normal insulation of the skin and subcutaneous tissue, which is why they do not have that auto-regulation. Sleep, everyone's favorite. Sleep is an active, multi-phase process that provides restorative function and promotes memory consolidation. Complex neural circuits in the hypothalamus, thalamus, brainstem, and cortex, interacting with hormones and neurotransmitters, control the timing of the sleep-wake cycle and coordinate the cycle with the circadian rhythm. Normal sleep has two independent phases that can be documented by electroencephalogram, an EEG. Rapid eye movement, REM sleep, and non-REM, slow wave sleep. NREM and REM sleep alternate, with each cycle lasting for about 90 to 100 minutes. Your NREM sleep is further divided into about 3 stages, your N1, 2, and 3, from light to deep sleep, followed by REM sleep. 4 to 6 cycles of REM and NREM sleep occur each night in an adult. The first cycle of the night begins with stage N1. The individual then progresses through stage N2, N3, and REM sleep. A new cycle beginning with stage N2 follows each REM sleep. With each successive cycle, the amount of time spent in stage N3 sleep decreases, and the amount of time spent in REM sleep increases. The individual who is awakened begins this next cycle with stage N1. So here we see how your REM sleep works in comparison with your non-REM sleep in various ages. A complex interaction of neural network and neurotransmitters promote wakefulness and sleep. The hypothalamus, brainstem, and basal forebrain are involved in promoting wakefulness. The neurotransmitters include brainstem and basal forebrain serotonin, norepinephrine, dopamine, acetylcholine, and glutamine. Hypothalamic wakefulness is associated with orexin and histamine. The production of these neurotransmitters decrease during sleep. Neurons in the preoptic area and basal forebrain induce sleep. The primary neurotransmitters are GABA and galanin. Other sleep promoters, particularly for NREM sleep, are melanin concentrating hormone and adenosine, prostaglandin D2, nitric oxide, and cytokines. Your ACH, GABA, and glutamate also promote REM sleep. The phases of sleep are based on changes in the EEG pattern. So here you see different patterns on an EEG. So awake, wakefulness with eyes closed and predominantly by alpha waves. They have an 8 to 25 hertz. Your NREM sleep, which is about 75 to 80% of sleep time, Again, it has those three stages, N1 through 3. So in N1, light sleep, your alpha waves are 6 to 8. Yeah, N2, further slowing of the EEG shows a 4 to 7 hertz. And I suppose it's important to note that your N1 sleep is light and cycle lasts only 10 to 12 minutes with slow eye movement, while your N2 can last 30 to 60 minutes and also has a presence of sleep spindles and slow eye movement. Your N3 low frequency is your 1 to 3 Hz, high amplitude delta waves with occasional sleep spindles, also known as slow wave sleep with no slow eye movement. And then your REM sleep time, most dreaming. So you have that non-rapid eye movement. Your non-rapid eye movement sleep or slow wave sleep is initiated when inhibitory signals are released from the hypothalamus. Sympathetic tone is decreased, and parasympathetic activity is increased during NREM sleep, creating a state of reduced activity. The basal metabolic rate falls by 10 to 15%. Your temperature decreases about half to 1% Celsius. Your heart rate, respirations, blood pressure, and muscle tone all decrease, and knee-jerk reflexes are absent. Pupils are constricted. During stages N1 and N2, cerebral blood flow to the brainstem and cerebellum also decrease. During stage 3, cerebral blood flow to the cortex is decreased. Growth hormone is released during stage N3 of sleep, and levels of corticosteroid and catecholamines are all depressed. Rapid eye movement sleep, that beautiful REM sleep, is initiated by the REM on and REM off neurons in the pons and mesencephalon. So when we turn on that beautiful REM, cells use the transmitter gamma aminobutyric acid, GABA, glycine, acetylcholine, and glutamate. When it gets turned off, the cells use the transmitters norepinephrine, epinephrine, serotonin, histamine, and GABA once again. REM sleep occurs about every 90 minutes, beginning 1 to 2 hours after NREM sleep begins. This sleep is known as the paradoxical sleep because the EEG pattern is similar to that of the normal awake pattern of the brain, is very active with dreaming. REM and NREM sleep alternate throughout the night, with lengthening intervals of REM sleep and fewer intervals of deeper stages of NREM sleep towards the morning. The changes associated with REM sleep include increased parasympathetic activity and variable sympathetic activity associated with rapid eye movement. Your anti-gravity muscle relaxation or atonia, loss of temperature regulation, altered heart rate, blood pressure, and respiration, penile erection in men, and guttural engorgement in women, release of steroids, and many memorable dreams. Respiratory control appears largely independent of metabolic requirement and oxygen variation. The loss of normal voluntary muscle control in the tongue and upper pharynx may produce some respiratory obstruction. Cerebral blood flow and brain oxygen consumption increase. So your pediatrics and sleep pattern. Sleep pattern of children changes as they age. Newborns sleep about 16 to 18 hours per day on an irregular schedule related to culture and parental and family influences. About 53% of that time is spent in active REM sleep. 23% in quiet sleep or NREM sleep, and the remainder of that in indeterminable phase. The infant sleep cycle is approximately 50 to 60 minutes long, with 20 minutes of NREM sleep and 10 to 45 minutes in the REM sleep cycle. In contrast to the adult sleep cycle, newborns enter REM sleep immediately on falling asleep and have well-developed sleep-wake cycling. At about the first year of age, an infant spends approximately 45% of total sleep in quiet sleep and 41% in REM sleep. Total sleep time decreases slightly from birth to 1 year. In the young child, the sleep cycle lengthens and is 45 to 60 minutes, in contrast to the 90 to 100 minutes in the adult. The child assumes the adult sleep pattern at some point during the first 3 to 5 years of life and sleeps between 9 and 10 hours per night. Sleep for infants and children is important for growth and neurocognitive development. Sudden infant death syndrome is presented in Chapter 37. Sleep disorders are common in children and include insomnia and dysomnias. Obstructive sleep apnea syndrome in children is related to an anatomic obstruction, a collapse of airway, and adenotonsillar inflammation. Your sleep deprivation in adolescence is associated with obesity, depression, anxiety, poor academic performance, and safety issues. So, aging and sleep patterns. The sleep pattern of the older adult differs from the younger adult or child and is variable among individuals. Total sleep time is decreased, and the older individual takes longer to initiate and maintain sleep. Older adults tend to go to sleep earlier in the evening and awaken more frequently during the night and earlier in the morning. That REM and NREM sleep decreases and the amount of time awake at night increases. Your decreased NREM sleep is more important in men over 70 years of age, or is more common rather, sorry. Changes in the older adult sleep pattern may be associated with loss of orexin synthesis or sensitivity, changes in lifestyle presence of chronic disease, lack of daily routine, desynchronization of the circadian rhythm, and the use of medicine. Growth hormone and cortisol level are diminished in the older adult and decrease slow wave sleep. The alteration in sleep pattern typically appears about 10 years later in women than it does in men. Older adults are less able than younger individuals to tolerate sleep deprivation, and good sleep quality in the middle age promotes better cognitive function and memory in older age. So, sleep disorders. Your classification of a sleep disorder is complex. A system has been established by the American Sleep Medicine and includes 4 classifications. Your dysomnias, which are disorders of initiating and maintaining sleep, and disorders of excessive sleepiness. Your parasomnias, your disorders that primarily do not cause a complaint of insomnia or excessive sleepiness. Sleep disorders associated with medical or psychiatric disorders. And then finally, the proposed sleep disorder. The most common dysomnias are parasomnias and are reviewed here. So, common dysomnias. The dysomnia are sleep disorders related to difficulty in initiating or maintaining sleep, or the presence of excessive sleepiness. The most common dysomnias include insomnia, restless leg syndrome, obstructive sleep apnea syndrome, circadian rhythm disorders, and hypersomnia. Insomnia is the inability to fall or stay asleep. It is accompanied by fatigue during wakefulness and may be mild, moderate, or severe. It may be transient, lasting a few days to months, and related to travel across time zones or caused by acute stress. Your chronic insomnia can be idiopathic, start at an early age, and be associated with drug or alcohol abuse, chronic pain disorders, chronic depression, the use of certain drugs such as amphetamines, steroids, central adrenergic blockers, bronchodilating agents, and caffeine, obesity, aging, genetics, and environmental factors that result in a hyperarousal, reduced cortical GABA, increased arousal during REM sleep, and dysregulation of sleep-wake cycles. Your restless leg syndrome is a sensory motor disorder associated with unpleasant sensation, that prickling, tingling, or crawling sensation, and a compelling urge to move the legs for relief that occurs at rest and is worse in the evening or at night. Sensation also may be experienced in the arms. The syndrome can lead to insomnia and affect the quality of life. The age of onset is usually anywhere between 30 to 40 and is more common in women and individuals with iron deficiency. Your restless leg syndrome has a familial tendency. It may be related to diurnal variation in iron transport across the blood-brain barrier and a loss of dopamine in the substantia nigra. Iron is a cofactor in dopamine production. Treatment includes alpha-2 delta drugs such as gabapentin, dopamine agonists, and iron administration. Your obstructive sleep apnea syndrome is a disorder of breathing during sleep related to the repetitive upper airway collapse, that obstruction, that is associated with the reduced blood oxygen saturation and hypercapnia. Your OSAs is the most commonly diagnosed sleep disorder, and estimated 1 to 5% in children, 9% of women, and 24% of men younger than 65 in the US are diagnosed with sleep disorder breathing. The incidence increases in those older than 65. Your major risk factors include obesity, being male, being older apparently is the other contributing factor, and postmenopausal status. The typical classification of the severity of the disease uses the apnea-hypopnea index. This index represents how many apneic episodes or hypoapnea episodes occur per night, the number of which is then divided by the night's total sleep time to give an average number of apnea or hypopnea episodes per hour. So your normal is 0 to 5, mild 5 to 15, moderate 15 to 29, and severe anything above 30. Your OSAs is increasingly prevalent in the rapidly expanding older adult population. Premenstrual women may be protected from sleep disorder breathing because the female hormone progesterone is a respiratory stimulant. The longer pharyngeal airway in males also may contribute to the increased risk of OSAs. Women have different symptoms than men, such as insomnia, restless leg, depression, nightmares, palpitations, and hallucinations. Men are more likely to be snoring and apneic episodes. Obese individuals often have a short, thick neck, pharyngeal airway collapse, impaired respiratory mechanics, and depressed respiratory control, particularly during sleep. Obesity, hypoventilation syndrome, may be related to leptin resistance because leptin is also a respiratory stimulant. It is important to note that the current obesity pandemic has not spared the pediatric population, and there has been an increased prevalence of OSAs among obese children. Your OSAs result from the parietal or total upper airway collapse related to pharyngeal anatomy or the decreased pharyngeal dilator muscle tone. There is obstruction to airflow recurring during sleep with excessive loud snoring, gasping, and multiple apneic episodes that last 10 seconds or longer. The periodic breathing eventually produces arousal, which interrupts the sleep cycle, reduces total sleep time, and sleep stage fragmentation, with REM deprivation. Associated conditions include a decreased sensitivity to carbon dioxide and oxygen tension, upper airway obstruction, a small airway and decreased pharyngeal dilator muscle activation. The level of negative intrathoracic pressure is the most likely stimulus for arousal, possibly mediated by the mechanoreceptors in the upper airway. Sleep apnea produces hypercapnia and low oxygen saturation, and eventually leads to the polycythemia, pulmonary hypertension, systemic hypertension, stroke, right-sided congestive heart failure, dysrhythmias, liver congestion, cyanosis, and peripheral edema. There also is an increasing recognition that OSAs may accelerate the loss of kidney function. The mechanism responsible for renal damage from OSAs is not clear, but activation of the renin-angiotensin system has been proposed as a contributor. Your laboratory polysomnography and home sleep testing are used to diagnose OSAs in addition to history and physical exam. Again, treatment is always going to be a positive airway pressure. Your dental devices, surgery of the upper airway and jaw in select individuals, and the management of obesity. Adenotonsillar hypertrophy is a major cause of OSA in children, and obesity increases that risk. Your adenotonsillectomy is a treatment of choice when that is the case. Your hypersomnia is excessive daytime sleepiness and is commonly associated with voluntary sleep deprivation. There may also be an underlying sleep disorder, such as OSAs or narcolepsy. Individuals may sleep while driving, working, or even conversing, resulting in significant concerns for safety. Treatment is symptomatic with reinforcement of good sleep habits. Your narcolepsy is hypersomnolence characterized as type 1 with excessive daytime sleepiness, cataplexy, which are brief spells of involuntary muscle weakness or paralysis, and hypocretin 1 deficiency, and type 2, absence of cataplexy and normal levels of hypocretin 1. The disorder is a REM sleep disorder with hypothalamic hypocretin or orexin deficiency and immune-mediated T-cell destruction of hypocretin secreting cells. There is a genetic association with HLA DQB1-0602 allele, infections and vaccinations, your H1N1 pandemics vaccine. Your older adults with narcolepsy are far less likely to have associated sleep disorders, such as OSAs and RLS. Your circadian rhythm sleep disorders are common disorders of the sleep-wake schedule and occur with rapid time zone changes, jet lag syndrome, in about 5 to 10% of shift workers. There is an alteration in sleep schedule with an advanced sleep-wake phase disorder, a delayed sleep-wake phase disorder, or 3 or more in sleep time, changes in sleep patterns from day to day. Your non-24-hour sleep-wake rhythm disorders, a problem occurring in totally blind individuals, apparently, and irregular sleep-wake rhythm disorder. These changes in the timing of established sleep schedule have been shown to desynchronize the circadian rhythm. Affected shift workers exhibit a decrease in vigilance, accuracy, and work performance, as well as an increased accident proneness. Individuals may experience short sleep episodes called microsleeps without being aware of decreased vigilance. For similar reasons, people suffering from jet lag syndrome requires several days to adapt to a new time zone. Travel across time zones requires 2 days to adjust the sleep-wake schedule. You have 5 days to adjust the body temperature cycle and 8 days to adjust cortisol level secretion. There is a need to phase delay sleep when traveling from east to west, and to phase advanced sleep when traveling from west to east. Your bright light exposure and administration of exogenous melatonin provide some success in retiming or resetting the body clock before or after time zone shifts. Sleep deprivation can result in neuropsychological effects, including 1. A marked impact on performance through decrease in cognitive function and specific effects on brain regions that support cognitive function. So your vigilance, attention, learning, memory, and decision making. 2. There's a decreased speed of mental processing. 3. A decline in attention and vigilance with distinct intra-individual variability. 4. Abnormal activation of the prefrontal cortex, parietal lobes, thalamus, and temporal lobes, as shown by functional neuroimaging. And 5. Task performance decreases as sleep debt accumulates in a manner that is dose-dependent. Your sleep disturbance and resultant sleep deprivation also are associated with increased risk for heart disease, your stroke, obesity, diabetes, infection, and depression. Sleep of poor quality and quantity also is now recognized as an important biomarker for cerebral pathologies other than just sleep disturbance related large and small vessel stroke. There has been an increasing recognition that insidious and progressive neurodegenerative diseases are now associated with sleep disorders. So, common parasomnias. Parasomnias are complex behavioral related to awakening from REM sleep or partial arousal from NREM sleep and disorders of sleep stage transition. 3 types of parasomnias include the arousal disorder, such as a confusional arousal, sleepwalking, night terrors, rearranging furniture, eating food, violent behavior, bruxism, which is your teeth grinding, and sleep enuresis. Sleep-wake transition disorders such as eurythmic movement, sleep talking, and nocturnal leg cramps, and disorders associated with REM sleep such as sleep paralysis and nightmares, sleep apnea, and SIDS, your sudden infant death syndrome. Parasomnias are more common in children and may be familial. Your REM sleep behavior disorders is loss of normal skeletal muscle atonia during REM sleep and may cause injury from the acting out of dreams. It is caused by the alterations in the brainstem circuits that mediate REM sleep atonia and is more common in older adult men. It is an early symptom, 5 years, associated with Parkinson's disease and other neurodegenerative diseases. Your somatosensory function and special senses. So, your somatosensory system include the peripheral receptors and central nervous system pathways that detect internal and external information, which is then processed and interpreted by the brain. This system includes touch, proprioception, and vestibular function, and the special senses, sight, hearing, smell, and taste. Touch. Touch is not a uniform sensory experience. The sensation of touch involves the fusion of several qualities, including modality, intensity, location, and duration of sensory stimulus. Receptors sensitive to touch are present in the skin, Meissner and Pacinian corpuscles are rapidly adapting receptors, whereas Merkel discs and Ruffini endings are slowly adapting touch receptors. Touch receptors are most numerous in the skin of the fingertips and lips, and are more scarce in the skin of the trunk. Specific sensory input is carried to higher levels by the CNS, by the dorsal column of the spinal cord and the anterior spinothalamic tract. Much of the development of the cutaneous senses takes place before birth, but structural growth of the cutaneous senses continues into early adulthood at a reduced rate. Then a gradual decline occurs. Studies have documented loss in tactile sensitivity with advancing age. This occurs simultaneously with an increase in the size of the Pacinian corpuscle and a decrease in the number of corpuscles. Abnormal tactile perception may be caused by alterations at any level of the nervous system, from the receptor to the cerebral cortex. Any factor that interprets or interrupts or impairs reception, transmission, perception, and interpretation of touch also alters tactile sensation. Your trauma, tumor, infection, metabolic changes, vascular changes, and degenerative diseases thus may cause tactile dysfunction, which may involve heightened or diminished tactile perceptions. In addition, most tactile sensations evoke affective responses that determine whether the sensation is unpleasant, pleasant, or neutral. Cerebral or hypothalamic centers influence this response. Sedative drugs and prefrontal injury, which interrupt connections between the prefrontal cortex and subcortical centers, diminish the interpretation of tactile sensations. Your proprioception. Proprioception, or perception and awareness of the position and movement of the body and its parts, depends on the impulses from the inner ear and from the receptors in joints and ligaments. The role of muscle, tendon, and cutaneous receptors is indefinite. Your sensory data are transmitted to higher centers, primarily through the dorsal column and the spinocerebellar tracts, with some data passing through the medial lemnisci and thalamic radiations to the cortex. These stimuli are necessary for the coordination of movement, the grading of muscular contraction, and the maintenance of equilibrium and postural control. A progressive loss of proprioception has been reported in older adults with increased risk for falls and injury. Proprioceptive dysfunction may be caused by alterations at any level of the nervous system. As with tactile dysfunction, any factor that interrupts or impairs the reception, transmission, perception, and interpretation of proprioceptive stimuli also alters proprioception. Two common causes of proprioceptive dysfunction are vestibular dysfunction and neuropathy. Specific vestibular dysfunction are vestibular nystagmus and vertigo. Vestibular nystagmus is the constant involuntary movement of the eyeball caused by ear disturbances. This condition occurs when a semicircular canal system is overstimulated. Vestibular vertigo, or dizziness, is the sensation of spinning that occurs with inflammation of the semicircular canals, or displacement of otoliths in the utricle and saccule of the semicircular canal system. The individual may feel either that he or she is moving in space, or that the world is revolving. Vertigo often causes a loss of balance and may be accompanied by nausea. Vertigo and nystagmus may occur in a variety of conditions, including labyrinthitis, vestibular neuritis, acute toxic labyrinthitis, benign paroxysmal positional vertigo, migrainous vertigo, and Meniere's disease. Meniere's disease, an endophthalmic hydrops, is an idiopathic episodic vestibular disorder resulting from neuroepithelial damage related to abnormalities in the quantity, composition, and pressure of the endolymph in the middle ear. The individual with Meniere's disease experiences vertigo, hearing loss, tinnitus, and oral fullness, and may have proprioceptive dysfunction and headaches. Standing or walking may be impossible because of the loss of balance. Meniere's syndrome, or secondary endophthalmic hydrops, is secondary to other conditions that alter the production or absorption of the endolymph. Peripheral neuropathies also can cause proprioceptive dysfunctions. Neuropathy may be the cause by a variety of conditions and commonly are associated with renal disease and diabetes. Although the exact sequence of events is unknown, neuropathies are thought to be caused by a metabolic disturbance of the neuron itself. The result is a diminished or absent sense of body position or positions of body parts. Gait changes often occur. Vision. The eyes are complex sense organs responsible for vision. Within a protective casing, each eye has receptors, a lens system for focusing light on the receptors, and a system of nerves for conducting impulses from the receptors to the brain. Visual dysfunction may be caused by abnormal ocular movements or alterations in visual acuity, refractions, color vision, and accommodation. Visual dysfunction also may be the secondary effect of another neurologic disorder. The external eye. Protective external eye structure include the eyelids, conjunctiva, the lacrimal apparatus. The eyelids are used to control the amount of light reaching the eye, and the conjunctiva line the eyelids. Tears released from the lacrimal apparatus bathe the surface of the eye and prevent friction, maintain hydration, and wash out foreign bodies and other irritants. So here's a picture of the eye duct. Infection and inflammatory response are the most common conditions affecting the supporting structures of the eyes. Blepharitis is the inflammation of the eyelids caused by a staphylococcus or seborrheic dermatitis. Redness, edema, tearing, and itching are common symptoms. An external hordeolum is an infection of the sebaceous gland of the eyelids, and an internal hordeolum is an infection of the eyelid margin. A chalazion is a non-infective lipogranuloma of the meibomian gland and may be associated with an internal hordeolum. These conditions present with redness, swelling, and tenderness and are treated symptomatically. Entropion is a common eyelid malposition in which the lid margin turns inward against the eyeball. In ectropion, the eyelids turn outward, away from the eye. Trichiasis is abnormally positioning eyelashes that grow back towards the eye. There are both surgical and non-surgical treatments to reposition the lid margin. Conjunctivitis, or red eye, is an inflammation of the conjunctiva. Conjunctivitis may be caused by bacteria, virus, allergies, or chemical irritants. The inflammatory response produces photophobia, visual blurring, redness, edema, pain, and lacrimation. Treatment is related to the cause. Your acute bacterial conjunctivitis, pink eye, is highly contagious and is often caused by a gram-positive organism, your Staphylococcus, Haemophilus, Streptococcus pneumonia, and Moraxella catarrhalis. Although other bacteria may be involved, the onset is acute, characterized by mucopurulent drainage from either one or both eyes. In children younger than 6, Haemophilus infection often leads to otitis media, preventing spread of the organism with meticulous hand washing and the use of separate towels is important. The disease often is self-limiting and resolves spontaneously in 10 to 14 days. Antibiotic eye drops usually are effective. Viral conjunctivitis is caused by an adenovirus. Again, it is contagious with symptoms of watering, redness, and photophobia. Some strains of virus cause conjunctivitis and pharyngitis, and other cause keratoconjunctivitis. Both diseases are contagious, with watering, redness, and photophobia. Treatment is symptomatic. Urologic conjunctivitis is associated with a variety of antigens, including pollen. Ocular itching is associated with photophobia, burning, and gritty sensation in the eye. Treatment is symptomatic and may include antihistamines, low-dose corticosteroids, mast cell stabilizers, and vasoconstrictors. Chronic conjunctivitis is the result of any persistent conjunctivitis. The cause requires identification for effective treatment. Trachoma, a chlamydial conjunctivitis, is caused by chlamydia, Trichomatis. It is often associated with poor hygiene and is the leading cause of preventable blindness in the world. The severity of the disease varies, but it can involve inflammation with scarring of the conjunctiva and eyelids, causing distorted lashes to abrade the cornea, leading to corneal scarring and blindness. A chlamydial organism are sensitive to local or systemic antibiotics, and the World Health Organization aims to eliminate trachoma as a public health problem by 2020, using the SAFE strategy, surgery for inturned lashes, antibiotics, facial cleanliness, and environmental improvements. So someone can Google that and see if that's been eradicated. I doubt it. I think COVID kind of threw a wrench into that one. Keratitis. Keratitis is an inflammation of the cornea that can be non-infectious or caused by bacteria, virus, fungi, or amoeba. Bacterial infections often cause corneal ulceration and require intensive antibiotic treatment. Your Staphylococcus aureus is the most common bacterial infection. Your type 1 herpes simplex virus can involve the cornea and conjunctiva. Predisposing factors include contact lens use, trauma, and penetrating keratoplasty. Your acanthoamoeba is associated with contact lens use and is a severe sight-threatening corneal infection. Common symptoms include photophobia, pain, and lacrimation. Severe ulceration with residual scarring require corneal transplantation. So, again, talking about the eye. The wall of the eye is formed of 3 layers: your sclera, your choroid, and your retina. The sclera is the thick, white outermost layer. It becomes transparent at the cornea, the position of the sclera in the central anterior region that allows light to enter the eye. The choroid is the deeply pigmented middle layer that prevents light from scattering inside of the eye. The iris, part of the choroid, has a round opening. The pupil, through which the light passes, smooth muscle fibers control the size of the pupil so that it can close vision and bright light. The pupil constricts, and in distant vision and dim light, the pupil dilates. So here is a picture of the eye. If you look at the top is the utmost outer side, and then at the very bottom is your optic nerve. So again, I'm going to leave this up for just a moment. Again, hit that pause button if you truly feel like you need it. Otherwise, we keep going. Here is the structure of the eyeball and the cell layers of the retina. Again, I'm going to leave this up for a moment. Again, pause so you can read all of it if you feel like I'm going too fast. The retina is the innermost layer of the eye and contains millions of rods and cones, special photoreceptors that convert light energy into nerve impulses. Rods mediate peripheral and dim light vision and are densest at the periphery. Cones, the densest in the center of the retina, are color and detail receptors. The photoreceptive rods and cones are distributed over the entire retina, except where the optic nerve leaves the eyeball. Lack of rods and cones in this area form the optic disc, or blind spots. Lateral to each optic disc is the macula, a yellow disc that absorbs ultraviolet light. The fovea centralis is a tiny central area of the macula that contains only cones and provides the greatest visual acuity. The optic nerve is composed of retinal cells, axons. As shown in the next figure, nerve impulses pass through the optic nerve after leaving the retinas. At the optic chiasm, the fibers from the inner halves of the retina cross to the opposite side, where they join fibers from the outer halves of the retinas to form the optic tract. The fibers of the optic tract synapse in the dorsolateral geniculate nucleus, and from there the geniculocalcarine fibers pass by way of the optic radiation to the primary visual cortex in the occipital lobe of the brain. Some fibers terminate in the suprachiasmatic nucleus and are involved in regulating the sleep-wake cycle. So, again, hit that pause button if you need it. Here, we're taking a look at the visual fields and possible defects. Light entering the eye is focused on the retina by the lens, a flexible biconvex crystal-like structure. In youth, the lens is transparent and has the consistency of hardened jelly. The flexibility of the lens allows a change in the curvature with contraction of the ciliary muscles. This is called accommodation, and it allows the eye to focus on objects in different distances. Anterior to the lens are the iris and the aqueous chamber, which is filled with aqueous humor. The aqueous humor helps to maintain the pressure inside the eye and provides nutrients to the lens and cornea. Aqueous humor is free-flowing fluid secreted by the ciliary process and reabsorbed into the canal of Schlemm. If drainage is blocked, pressure within the eye increases, such as with glaucoma. Posterior to the lens is the vitreous chamber, which is filled with a gel-like substance called vitreous humor. Vitreous humor helps prevent the eyeball from collapsing inward. The central retinal artery provides blood to the inner retinal surface. Nutrients and oxygen are supplied to the outer surface of the retina by the choroid, a vascular layer that lies between the retina and the sclera. 6 extrinsic eye muscles attached to the outer surface of each eye allow gross eye movement and permit the eye to follow a moving object. So here you have the extrinsic muscles of the right eye. Again, hit pause if you need to remember your muscle groups. So aging and vision. Changes in visual and motor components of the eye caused by aging begin at an early age, particularly in the lens of the eye. Changes caused by aging are summarized here on this table. Structural changes combined with chronic disease, including dementias and diabetes, result in a decline in visual acuity and the extraocular motor for muscle function. So here you have different structures, the change, and its consequence. So again, hit pause, go ahead and read this. Make flashcards, do what you need to remember this. Visual dysfunction. Abnormal ocular movement occurs as a result of oculomotor trochlear or abducens cranial nerve dysfunction. The three types of eye movement disorders are strabismus, nystagmus, and paralysis of the individual extraocular muscle. Strabismus is the deviation of one eye from the other when a person is looking at an object. It results in failure of the two eyes to simultaneously focus on the same image, and therefore loss of binocular vision. The deviation may be upward, downward, inward, or outward, resulting from a weak or hypertonic muscle in one of the eyes. Strabismus may be caused by a neuromuscular disorder of the muscle eye, diseases involving the cerebral hemisphere, or thyroid disease. The primary symptom of strabismus is diplopia, or double vision. Strabismus in children requires an early intervention to prevent the development of amblyopia, the reduced vision in the affected eye without ocular pathology and with full optical correction. Surgery may be helpful to both children and adults with strabismus. Nystagmus is an involuntary unilateral or bilateral rhythmic movement of the eyes and can occur in infants or adults. It may be present at rest or it may occur with eye movement. The two major forms of nystagmus are pendular nystagmus and jerk nystagmus. Pendular nystagmus is characterized by a regular, alternating forward and backward movement of the eyes, in which both phases of the movement are equal in length. In jerk nystagmus, one eye or one phase of the eye movement is faster than the other. Nystagmus may be caused by an imbalance in the normally coordinated reflex activity of the inner ear. Vestibular nuclei, the connecting the vestibular nerve with the vestibular tract, cerebellum, medial longitudinal fascicle, or nuclei of the oculomotor trochlear and abducens cranial nerve. Drugs, retinal disease, and diseases involving the cervical cord also may produce nystagmus. Infantile nystagmus syndrome has an unknown pathogenesis. The syndrome develops in the first 6 months of age and is more prevalent in males. Ocular motor control and anterior visual pathways disturbances are under investigation. One disease-causing gene has been identified as an X-linked FRMD7. There may be an associated strabismus, amblyopia, torticollis, or visual impairment. Untreated nystagmus can lead to a loss of visual acuity. Paralysis of specific extraocular muscles may cause a variety of abnormalities, including limited abduction, abnormal closure of the eyelid, ptosis or drooping of the eye, and diplopia. The abnormalities occur as a result of unopposed muscle activity. Trauma or pressure in the area of the cranial nerves may cause paralysis of the specific extraocular muscles. Diseases such as diabetes and myasthenia gravis also may affect specific extraocular muscles. Alterations in visual acuity. Visual acuity is the ability to see objects in a sharp detail. With advancing age, the eye's lens becomes less flexible and less adjustable, and visual acuity declines. Visual acuity also may change or diminish for many other reasons. Specific causes of visual acuity changes include amblyopia, scotoma, cataracts, papilledema, dark adaptation, glaucoma, a retinal detachment, and macular degeneration. Amblyopia, or lazy eye, is a reduction or dimness of vision related to altered development of the visual cortex and is the most common cause of childhood monocular blindness. It does not result from a change in refraction or from any visible change in the eye. Amblyopia is associated with a strabismus, anisometropia, ametropia, stimulus deprivation, with disease such as diabetes, renal failure, and malaria, and with toxic substances such as alcohol and tobacco. Early detection is required to restore vision. Treatment includes patching of an unaffected eye for extended times to ensure a period of use of the affected eye, or administering atropine eye drops, blurring vision. Research related to brain plasticity with bilateral treatment approaches include visual perceptual learning and video gaming is promising for visual restoration in both children and adults. Refractive errors are treated with corrective lenses. A scotoma is a circumscribed defect of the central field of vision. It can be caused by lesions of the central retina or the sequela to demyelinating optic neuritis, an inflammatory lesion of the optic nerve, frequently associated with optico-spinal multiple sclerosis. Age-related macular degeneration is associated with scotoma. Less common causes include the compression of one optic nerve by a retroorbital tumor, neuromyelitis optica. Pernicious anemia and toxic or metabolic causes, such as a methyl alcohol poisoning or the use of tobacco. The precise mechanism for these conditions causing a scotoma are uncertain, but the result is always a serious impairment in visual acuity. A cataract is a cloudy or opaque area in the ocular lens and leads to the visual loss when located on the visual axis. The incidence of cataracts increases with age as the lens enlarges. Cataracts develop because of alterations of metabolism and transport of nutrients within the lens. Although the most common form of cataract is degenerative, cataracts also may occur congenitally or as a result of an infection, radiation, trauma, drugs, or diabetes. Cataracts cause decreased visual acuity, blurred vision, glare, and decreased color perception. Cataracts are treated by removal of the entire lens and replacement with an intraocular artificial lens. Dark adaptation also affects visual acuity. Low illumination causes impaired visual acuity, particularly in the older adult. The average 80-year-old person needs more than twice as much light as the 20-year-old person to see equally well. Changes in the quantity and quality of rhodopsin, a substance found in the rods and responsible for low light vision, are thought to be responsible for reduced dark adaptation in older adults. A vitamin A deficiency can cause the same phenomenon in individuals of any age. Glaucoma is the second leading cause of blindness and are characterized by intraocular pressure greater than 12 to 20 milligrams of mercury, with death of retinal ganglion cells and optic nerve axons. Family history is a risk factor, and several glaucoma-associated genes have been identified. The types of glaucoma are summarized in the following tables. Most forms of glaucoma are associated with resistance to aqueous humor outflow. Primary open-angle glaucoma is the most common and is associated with alterations in the trabecular meshwork. Chronic increased intraocular pressure causes death of retinal ganglions and optic nerve degeneration, with loss of peripheral vision, followed by the central vision impairment and blindness. Extremely high pressures can cause blindness within days or hours. Loss of vision acuity results from pressure on the optic nerve, which is believed to block the flow of cytoplasm from neuronal bodies in the retina to peripheral optic nerve fibers entering the brain. Lack of nutrients, ischemia, oxidative stress associated with mitochondrial failure, inflammatory cytokines, excessive apoptosis, and altered immune mechanisms may lead to death of the involved neurons. Initially, there are no symptoms. With increasing pressure, acuity pain may result, and there is loss of peripheral vision and progression to blindness. Early detection and treatment prevent optic neuropathy and visual impairment. Screening programs assist in identifying the silent disease. Glaucoma is treated with pharmaceutical eye drops to reduce secretion or increase absorption of aqueous humor. Surgery may be needed to open the space of the trabecula and reduce intraocular pressure. Neuroprotective therapies are being evaluated at this time. So here are the different types of glaucoma. Again, I would say hit the pause button, take a look, make some note cards, flashcards, just so that you know them. It's not so much that I believe that we need to know this for this program itself, for advanced pathophysiology, but more for the next portions of our courses, especially again, the advanced health assessment. Here is glaucoma, an open angle glaucoma. Again, hit pause if you need to review your anatomy. Retinal detachment is a common cause of visual impairment and blindness. Risk factors include retinal holes and vitreoretinal traction. Fluid separates the photoreceptors from the retinal pigment epithelium. The separation deprives the outer retina of oxygen and nutrients because the diffusion distance is increased. Communication is also disrupted between the pigment epithelium and photoreceptors. Rhegmatogenous retinal detachment is the most common form of retinal detachment. Causes include intracapsular cataract extraction, severe myopia, age-related lattice degeneration, vitreoretinal traction, and trauma. Contraction of fibrous membranes can cause tractional separation of the retinal layers, as occurs in proliferative diabetic retinopathy. Treatment involves immediate surgical retinal reattachment. Your age-related macular degeneration is a severe and irreversible loss of vision and a major cause of central blindness in older adults. Risk factors include old age, hypertension, cigarette smoking, diabetes, previous cataract surgery, and a family history of age-related macular degeneration. The degeneration usually occurs after the age of 60. There are two forms, atrophic and neovascular. The atrophic form is more common and is slowly progressive with inflammation and the accumulation of lipofuscin and drusen in the retina. Symptoms include limited night vision and difficulty reading. The neovascular form includes the accumulation of drusen and lipofuscin, abnormal choroidal blood vessel growth, leakage of blood or serum, retinal detachment, fibrovascular scarring, loss of photoreceptors, and more severe and rapid loss of central vision. Treatment for wet AMD includes antivascular endothelial growth factor injections. New treatments under investigations. Two carotenoids, lutein and zeaxanthin, are antioxidants that selectively accumulate in the macula. Supplements of lutein and zeaxanthin may enhance vision in early dry AMD. Alterations in accommodation. Accommodation is the process whereby the thickness of the lens changes with the contraction of the ciliary muscles. Accommodation is needed for clear vision and is mediated through the oculomotor nerve. Again, that's that cranial nerve number 3. Pressure, inflammation, and disease of the oculomotor nerve may alter accommodation. Symptoms include diplopia, blurred vision, and headaches. Loss of accommodation in adults begins at the age of 45 to 50 and is termed presbyopia, a condition in which the ocular lens becomes larger, firmer, and less elastic in response to ciliary muscle contraction. The major symptom is reduced near vision, causing the individual to hold reading material at arm's length. Correction of presbyopia is accomplished through reading glasses or bifocal lenses, the accommodative intraocular lenses, or surgical treatment. Your alterations in refraction. Alterations in refraction is the most common visual problem. Errors in refractions are caused by irregularities of the corneal curvature, the focusing power of the lens, and the length of the eye. The major symptom of refraction alterations are blurred vision and headache. 3 types of refraction alterations are myopia, hyperopia, and astigmatism. So here we see the different alterations in refraction. If you need to read that, go ahead and hit pause, otherwise I keep going. In myopia, your nearsightedness. The axis of the eyeball is lengthened and light rays are focused in front of the retina when a person is looking at a distant object, resulting in blurred vision. The cause is unknown. A concave lens is needed for correction. Myopia requires frequent changes of eyeglasses while the eyeball is lengthening in childhood. Myopia is a risk factor for retinal detachment, cataract formation, and glaucoma. In hyperopia, your farsightedness, the axis of the eyeball is too short, and the light rays are focused behind the retina when a person is looking at a near object. Astigmatism is caused by an unequal curvature of the cornea. In astigmatism, light rays are bent unevenly and do not come to a single focus on the retina. Astigmatism may coexist with myopia, hyperopia, or presbyopia. Hyperopia is corrected with a convex lens or a laser refractive surgery. Alterations in color vision. Normal sensitivity to color diminishes with age because of the progressive yellowing of the lens that occurs with aging. All colors become less intense, although color discrimination for blue and green is most greatly affected. Color vision deteriorates more rapidly for individuals with diabetes than for the general population. The deterioration is thought to be an accelerated version of senile color vision deterioration. Abnormal color vision also may be caused by color blindness, an inherited trait. Color blindness is generally an X-linked recessive characteristic affecting 6 to 8% of the male population and 0.5% of the female population. Although many forms of color blindness exist, most commonly the affected individual cannot distinguish red from green. The most severe form individuals only see shades of gray, black, and white. Your neurologic disorders causing visual dysfunction. Various neurologic disorders may cause a visual dysfunction. Visual vision may be disrupted at many points along the visual pathway, causing a variety of defects in the fields of vision. Visual changes do not always cause defects or blindness in the entire visual field. Euhemianopia is the term that describes defective vision in a half of the visual field. The following figure illustrates many areas where the visual path that may be damaged and the associated visual changes. Because of the anatomy of the optic nerve, injury to the optic nerve causes ipsilateral blindness, but a normal contralateral visual field. Injury to the optic chasm, often caused by atherosclerotic ischemia, or external compression from trauma or aneurysm, can cause a variety of defects, depending on the location of injury. These defects vary because of the optic chiasm. Nerve fiber from the medial half of each retina separate from the lateral half and enter the opposite optic tract. Because of the normal structure of the visual pathways, destruction of one optic tract causes a homonymous hemianopsia, or complete loss of vision in the inner half of one eye and the outer half of the other. Thus, if an injury to the left optic tract occurs, the individual is blind in the right medial inner eye or field and the left eye's lateral outer field. If the compression of the optic tract is asymmetric, an incongruous, homonymous defect results. Injury to one optic radiation also causes a homonymous defect. A major injury in the optic radiation causes a homonymous hemianopsia. A lesser injury may cause an upper quadrant homonymous defect. Generally, the defects are the same size in both eyes. When the homonymous hemianopsia is caused by an occipital lobe lesion, the area of hemianopsia is split, although visual acuity may remain unimpaired. Reading is difficult because of the inability to group words. Papilledema is edema of the optic nerve at its point of entrance into the eyeball. Papilledema is caused by an increased intracranial pressure, such as brain tumors, intracranial hemorrhage, or hydrocephalus. The subarachnoid space of the brain is continuous with the optic nerve sheath. As cerebrospinal fluid pressure increases, the pressure is transmitted to the optic nerve, and the optic nerve sheath compresses the nerve and impedes axoplasmic transport. This leads to accumulation of axoplasmic substances at the level of the lamina cribrosa, resulting in the characteristic swelling of the optic disc. Obliterations of the physiologic cup follows. Later, the optic disc becomes raised above the level of surrounding retina, and the margins become blurred and indistinct. With severe swelling, hemorrhage, and patches of white exudate surround the disc margins. The edematous nerves compress the small retinal veins, causing venous stasis and engorgement. Headache is common, and there may be no visual change, blurred vision, or constriction of the visual fields. Your hearing. Hearing, the external auditory canal, is surrounded by bones of the cranium. The opening meatus of the canal is just above the mastoid process. The air-filled sinuses, called mastoid air cells, are located in the mastoid process and promote the conductivity of sound between the external and the middle ear. Mastoid air cells communicate with the middle ear cavity through the entrance to the mastoid antrium. So here you have a picture of the ear. Again, hit pause if you need to get that refresher for anatomy. The ear is divided into three areas. The external ear, involved only with hearing. The middle ear, involved with hearing, and the inner ear, involved with both hearing and equilibrium. The external ear is composed of a pinna, or auricle, which is the visible portion of the ear. The external auditory canal, a tube that leads to the middle ear, and sound waves entering the external auditory canal hit the tympanic membrane, the eardrum, and cause it to vibrate. The tympanic membrane separates the external ear from the middle ear. The middle ear is composed of the tympanic cavity, a small chamber in the temporal bone, three ossicles. The small bones, known as the malleus, the hammer, the incis, the anvil, and the stapes, the stirrup, transmit the vibration of the tympanic membrane to the inner ear. When the tympanic membrane moves, the malleus moves with it and transfers the vibration to the incis, which passes it to the stapes. The stapes presses against the oval window, a small membrane of the inner ear. The movement of the oval window sets the fluid of the inner ear into motion. So here we're looking at more anatomy. The inner ear, the bony labyrinth. Again, hit pause if you need to grab a quick AP refresher. The eustachian or pharyngeotympanic tube connects the middle ear with the thorax, normally flat, and closes the eustachian tube open. Briefly, when a person swallows or yawns, it equalizes the pressure in the middle ear with atmospheric pressure. Equalized pressure permits the tympanic membrane to vibrate freely through the eustachian tube. The mucosa of the middle ear is contiguous with the mucosal lining of the throat. The inner ear is a system of osseous labyrinths filled with a fluid called perilymph. The bony labyrinth is divided into the cochlea, the vestibule, and the semicircular canal. Suspended in the perilymph is the endolymph-filled membranous labyrinth that basically follows the shape of the bony labyrinth. Within the cochlea of the organ of Corti, which contains hair cells, sound waves that reach the cochlea through vibration of the tympanic membrane, ossicles, and oval windows set the cochlear fluid into motion. Receptor cells on the basilar membrane are stimulated when the hairs are bent or pulled by the movement. Once stimulated, hair cells transmit impulses along the cochlear nerve to the auditory cortex of the temporal lobe in the brain, where interpretation of the sound occurs. Directional hearing is controlled by the angle of the sound source to both ears and by the axonal delay in conduction in groups of neurons. The semicircular canals and vestibule of the inner ear contain equilibrium receptors. In the semicircular canals, the dynamic equilibrium receptors respond to changes in direction of movement. Within each semicircular canal is the crista ampullaris, a receptor region composed of a tuft of hair cells covered by a gelatinous capula. When the head is rotated, the endolymph in the canal lags behind and moves in the direction opposite to the head's movement. The hair cells are stimulated, and impulses are transmitted through the vestibular nerve to the cerebellum. The vestibular in the inner ear contains a macula, receptors essential to the body's sense of static equilibrium. As the head moves, otoliths move in a gel-like material in response to changes in the pull of gravity. The otoliths pull on the gel, which in turn pull on the hair cells in the macula. Nerve impulses in the hair cells are triggered and transmitted to the brain. Thus, the ear not only permits the hearing of a large range of sounds, but also assists with the maintaining balance through the sensitive equilibrium receptors. So, how does aging affect our hearing? Your presbycusis is the loss of hearing in older adults. Auditory changes caused by the aging is common, incremental, and with considerable individual variation. Changes in hearing with aging is summarized in the following table. Roughly 30 to 40% of people older than 65 have a type of hearing loss caused by genetic and environmental factors. Changes may occur in the structural and functional components of the peripheral and central auditory system. Accumulation damage to the middle ear and inner ear, particularly of hair cells, and the cochlea is caused by damaging factors such as noise, inflammation, toxins, oxidative stress, and vascular damage. So again, here's that small table. Hit pause if you feel the need to read this and make some flashcards. Your ototoxic drugs include antibiotics such as streptomycin, neomycin, gentamicin, and vancomycin. Your diuretics such as ethacronic acid and Lasix, chemicals such as salicylate, your quinine, carbon monoxide, nitrogen mustard, arsenic, mercury, gold, tobacco and alcohol, and cancer drugs like cisplatin. Because of the increased concentrations of antibiotics in the endolymph, these drugs generally cause damage to the cells of the cochlea or the hair cells of the organ of Corti. Diuretics affect hearing primarily by altering the sodium-potassium balance, causing extracellular fluid accumulation and changes in the microstructure of secretory cells. Your quinine, mercury, and lead affect the neural pathway of hearing, including the spinal ganglia, the eighth cranial nerve, and the cochlear nucleus. Loss of hearing for sound in the high frequency range is most common in interferences with understanding speech, particularly high frequency consonant sounds, your S, your sh, and your F. Hearing may be lost in both ears, but not at the same time. The ability to discriminate localization of sound varies with high and low frequencies and diminishes with age. In the low frequency range, sound localization is a function of timing of sound arrival between the two ears. Localization of high frequency sounds is a function of sound intensity. Because older adults tend to lose high frequency hearing first, they may have difficulty localizing high frequency sounds and understanding speech. Cognitive impairment and poor quality of life are associated with presbycusis. Auditory dysfunction. Between 5 to 10% of the general population have a hearing impairment. The major categories of auditory dysfunction are conductive hearing loss, sensory neural hearing loss, mixed hearing loss, and functional hearing loss. Your conductive hearing loss occurs when a change in the outer or middle ear impairs sound from being conducted from the outer to the inner ear. Conductive hearing loss occurs when there is interference in air conduction. Conditions that commonly cause a conductive hearing loss include impacted cerumen, foreign bodies lodged in the ear canal, benign tumors of the middle ear, carcinoma of the external auditory canal or middle ear, eustachian tube dysfunction, otitis media, acute viral otitis media, chronic suppurative otitis media, cholesteatoma, and otosclerosis. Symptoms of conductive hearing loss include diminished hearing and soft speaking voice. The voice is soft because often the individual hears his or her voice, conducted by bone, or as loud. In addition, although the cause is unknown, the individual often hears better in noisy environment than in quiet one. Treatment of the underlying cause generally improves hearing, and a hearing aid can improve the quality of life. Sensory neural hearing loss. A sensory neural hearing loss is caused by impairment of the organ of Corti, or its central connection. The hearing loss may be gradual or sudden. Conditions that commonly cause sensory neural hearing loss include congenital and hereditary factors, noise exposure, age, Meniere's disease, ototoxicity, and systemic disease. Congenital and neonatal sensory neural hearing loss may be caused by maternal rubella, cytomegalovirus, ototoxic drugs, prematurity, traumatic delivery, erythroblastosis fetalis, and congenital hereditary malfunction. Your diagnosis often is made when delayed speech development is noted. Treatment includes hearing aids and cochlear implants. Gene therapy and allotransplantation of stem cells are under investigation. Your mixed hearing loss is caused by a combination of conductive and sensory neural losses. Your functional hearing loss occurs for no organic reason. The individual does not respond to voice and appear not to hear. Your functional hearing loss is thought to be caused by emotional or psychologic factors. It occurs only rarely. Your ear infections. Your otitis externa is inflammation of the external ear canal with or without infection and may include parts of the outer ear. It is commonly acute rather than chronic. Regular swimming is a risk factor. Alterations in the normal acidic environment, lack of cerumen, and trauma to the skin epithelium can lead to bacterial and, less commonly, fungal infection with inflammation. The most frequently found microorganisms are Pseudomonas, E. coli, and Staphylococcus aureus. Infection usually follows prolonged exposure to moisture. The earliest symptoms are inflammation with swelling, tenderness, and itching with clear drainage, progressing to purulent drainage and obstruction of the canal. Treatment includes topical antibiotics and steroids. Your otitis media is an infection of the middle ear and is the most common infection in infants and children. Otitis media is the leading cause of healthcare visits and drug prescriptions throughout the world, with 50% occurring in the under 5-year age group. Most children have one episode by 3 years of age. The most common pathogen are Haemophilus influenza, Moraxella catarrhalis, Streptococcus pneumonia, and Staphylococcus aureus. Respiratory viruses also may have an etiologic role. Predisposing factors include allergy, sinusitis, submucosous cleft palate, adenoidal hypertrophy, and immune deficiency. Breastfeeding is a protective factor. Acute otitis media is associated with ear pain, fever, irritability, inflamed tympanic membrane, and a fluid in the middle ear. The tympanic membrane progresses from the erythema to the opaqueness, with a bulging as fluid accumulates. An increasing prevalence of AOM is caused by methicillin-resistant microorganisms. Your otitis media with effusion, or OME, is the presence of fluid in the middle ear without symptoms of acute infection. Treatment includes antimicrobial therapy for AOM, particularly in children 2 years and younger. Reduction in the incidence of AOM has accompanied the widespread use of bacterial and viral vaccines in young children, including pneumococcal conjugate and influenza vaccines. Your chronic otitis media is persistent or recurring infection of the middle ear. Chronic suppurative OM is associated with eardrum perforation and purulent discharge. Conductive hearing loss occurs when the effusion prevents the middle ear ossicles from effectively relaying sound vibration from the eardrum to the oval window of the inner ear. Sensory neural hearing loss occurs when the inflammatory mediators penetrate into the inner ear through the round window with loss of hair cells in the cochlea. Placement of your tympanostomy tubes is considered when bilateral effusion persists for 3 months and for significant hearing loss. A mastoidectomy combined with a tympanostomy ventilation tube may be required when there is cholesteatoma. Complications include mastoiditis, brain abscess, meningitis, chronic otitis media with hearing loss, speech, language, and cognitive disabilities may be affected by persistent middle ear effusions. Eosinophilic COM is associated with bronchial asthma and with sensitization to bacterial or fungal ear infections. The olfactory and taste. Olfactory smell dysfunction and taste gustation dysfunction may occur separately or jointly. The strong relationship between smell and taste create the sensation of flavor. If either sensation is impaired, the perception of flavor is altered. So here we have the olfaction. Again, hit pause if you need this. Olfaction is a function of cranial nerve 1, the olfactory, and part of cranial nerve 5, trigeminal. The receptor cells for smell are located in the olfactory epithelium. 7 primary classes of olfactory stimulants have been identified: camphoraceous, musky, floral, peppermint, ethereal, pungent, and putrid. Olfactory is important for detection of hazards in the environment, generating feelings of pleasure, promoting adequate nutrition, influencing sexuality, and maintenance of mood. Olfactory dysfunction include hyposmia, anosmia, hallucinations, and parosmia. Hyposmia is the impaired sense of smell, and anosmia is the complete loss of smell. Both conditions are associated with aging, neurodegenerative and nasal sinus disorders, and head trauma. When hyposmia or anosmia occurs bilaterally, it is usually the result of rhinitis, sinusitis, nasal polyps, or excessive smoking. Unilateral hyposmia or anosmia may indicate compression of one olfactory bulb or nerve tract, possibly by tumor or head trauma. Olfactory hallucinations arise from the hyperactivity in cortical neurons and involve smelling odors that are not really present. They are associated with temporal lobe seizures and rarely with schizophrenia. Parosmia, an abnormal or perverted sense of smell, may occur with severe depression and in Parkinson's and Alzheimer's disease. Taste is a function of multiple nerves in the tongue: soft palate, uvula, pharynx, and upper esophagus, including cranial nerves 7 and 9, the facial and glossopharyngeal. Taste buds, fungiform, foliate, and circumvallate, sensitive to each of the primary sensations, are located in specific areas of the tongue and are continuously renewing. The primary sensation of taste are sour, salty, sweet, bitter, and umami, or savory. Taste buds, sensitive to each of the primary sensations, are located on the circumvallate, fungiform, and foliate papillae in specific areas of the tongue. Taste receptors also are found on airway smooth muscle for bitter and in the gastrointestinal tract, bitter and sweet. Their function is not for taste. In the lung, they stimulate bronchodilation, and in the GI tract, they may participate in metabolic and digestive regulation. Your alteration in taste can be caused by injury, medication, oral infections, or aging. A change in taste also may be attributable to impairment of smell associated with injury near the hippocampus. Hypogeuasia is a decrease in taste sensation, and aguasia is the absence of taste. Aguasia affecting the entire tongue may follow head injury. Hypogeuasia and aguasia occur with viral respiratory and, and oral infections. Autoimmune, such as systemic lupus and cancer chemotherapy, can alter taste sensitivity. Damage to the glossopharyngeal nerve causes the loss of the ability to detect bitterness. This loss occurs because the receptors for bitter are located on the base of the tongue. Damage to the facial nerve, the cranial nerve 7, which innervates the anterior two-thirds of the tongue, causes loss of the ability to detect sour, sweet, and salty taste. Only bitter tastes can be detected. These losses occur because sour, sweet, and salt receptors are located on the anterior portion of the lung. Aging and olfaction and taste. So sensitivity to odors decline steadily with aging. A study of odor identification indicates an increasing ability from childhood to adolescence and then a decline at 60 years of age. The sense of smell begins to degenerate with loss of olfactory sensory neurons and loss of cells from the olfactory bulbs. The mechanism of loss is unknown. Loss of olfactory sensitivity and odor identification may diminish the appetite and food selection, and thus may lead to malnutrition. Safety also may be compromised by an inability to smell spoiled food or hazardous gases. Pareidosia is a perversion of taste, in which substances possess an unpleasant flavor. Pareidosia occasionally develops for no apparent reason in older adults, leading to anorexia and malnutrition. The decline in taste sensation is more gradual than that of smell and is associated with a loss of olfaction. Higher concentrations of flavors are required, and older adults have difficulty differentiating combinations of flavors. Taste changes with aging are associated with a decline in the number of fungiform papillae on the tongue and changes in taste receptor function. Taste also may be affected by decreased salivary gland secretion. Amylase contained in the saliva facilitates perception of sweet flavors. And that concludes our chapter here. So I will see you with chapter 17, alterations in cognitive systems, cerebral hemodynamics, and motor function. I shall see you there. I hope you have a wonderful day.